Right, so next slide. This slide talks about just all the populations really that have a connection here to the hospital. So although New Hampshire Hospital serves a finite number of individuals, the impact that we have on towns, communities, businesses, and health systems spans nearly every facet of the state.
So I have a
So,
question back on that slide too,
sure,
sorry.
that's okay.
I hope Ms. Rounds warned you. I tend to do this, but okay. So as your circle is outside there, I'm not actually seeing emergency rooms. And the reason that is relevant is, historically, I think there's a better word than warehousing, but for a few years we were warehousing people that needed inpatient care at the New Hampshire Hospital in ERs, and we were using up a whole lot of their capacity, sometimes a third of their emergency room capacity. So it seems to me like that's one of our key populations that we serve are the state's emergency rooms. And I'm just curious how we're doing these days on allowing the flow of patients from ERs into New Hampshire Hospital. Or is there a slide on that, or is this the right slide to talk about that?
There is more detail later. I would agree with you that, under that circle of hospitals, more specifically, a direct impact is on the emergency department. And yes, we have more detail later in the presentation about referrals, about wait list, and the issue of boarding.
Oh, wait, thanks.
Okay. So this slide just talks about what the scope of service is here at New Hampshire Hospital and what we do and what we don't do. At this point, we've talked a lot about what the hospital does, but we want to be clear about what we don't do. So New Hampshire Hospital does not provide substance use treatment unless it's secondary to a serious mental illness. So for a patient to be here at New Hampshire Hospital, substance use disorder cannot be the primary diagnosis. We do not have our own in-house diagnostic services, such as pathology or radiology, and we don't provide any outpatient service to the community. This slide just shows our team, our New Hampshire Hospital state employee team. Just to give you some context on who's working here at the hospital and also their years of service. I think what's great about the team is that we really have representation among definitely different skill sets. Some of our leaders have been here for, well, you can see Rosie Costanzo, our Chief Nursing Officer, 33 years, Cindy Babonis, 20 years, Beth Nagy, 22. And then there are folks like myself, Joe Christie, Ellen LaPointe, who are newer to state service, but have worked in the private sector and bring that skill set. So I think it's a great combination as a resource for the hospital. So moving on to key performance indicators. Over the past few years, the hospital's made a concerted effort to design our strategic plan around the needs of citizens across New Hampshire. We've come to find that these needs translate into 5 objectives for our organization: delivering high quality care, creating timely access to care, maintaining fiscal stewardship, providing an exceptional patient experience, and improving employee well-being. From those objectives, we have numerous metrics, but in being 100% transparent, the hospital's collective effort primarily focuses on just one of these strategic imperatives, and that's creating timely access to care or reducing the emergency room boarding, which I think was what you were referencing earlier, Chairman. This slide refers to referrals over time through the years. And you can see that it's remained relatively flat for adults. But although referrals remain relatively flat, the wait list continues to grow, particularly over the past year during the pandemic. Likewise, as the wait list grows, the problem of emergency room boarding grows.
Is there a separate slide on to summarize the boarding problem? Is this it?
This is part of it. Yep, we'll get into children as well in more detail.
So just to make sure I'm reading this right, in 2012, we hit 1,913 adult patients who were in emergency rooms that had been identified as needing admission to the New Hampshire hospital.
That's by days. So that represents the patient, but also the number of days that they were waiting.
So if it was one guy for a week, that would be 7 of that 1913.
You got it. Yep.
Representative Wallner has a question.
I think you just answered. I didn't realize that was days, and I wanted to know what the average number of people in emergency rooms by day was.
I might have that on another slide. If it's okay, I'll keep going. And if I
just
don't, go ahead.
Just one more that you might if I have.
I'm sorry, I still find you, Representative Wallner. Do you have a follow-up? Would you like to keep talking? That's okay.
Yeah, no, I just have one more question. She may have the information. Just what is the average stay in the emergency room? Do you have that? How long do people wait in the emergency room?
We can get that for you. I know we have that. I'm just making a note. I'll get that.
That would be actually kind of a cool thing to do with this slide, is to use the right side of it as the average length of boarding, so that we could see it overall. But I'm a little disappointed in this slide because I had heard anecdotally that we had solved this problem in the last budget, and I don't consider 1,400 patient days to be solved. What's it going to take to bend this curve down in an aggressive, appropriate manner?
Thank you for the question. I think this is a great slide because it does show the progress that we made between 2017 right up to 2020. And you see that significant dip in March of 2020. So over time we were, and we'll get the information about the average number of days waiting, but I can tell you that that had been trending down significantly over these period of years since 2017. What you see on this slide is during the period of time between 2019 and 2020, we developed the contract with Hampstead Hospital. We started transitioning children's services to them beginning in January, and then we escalated that in March due to the pandemic. We had been having kids admitted there by attrition, but because of the emergency really within the pandemic in March, we aggressively approached that and worked with Hampstead to transfer kids over. So there was a period of days in March where we had no wait list. We opened up adult beds, we increased access, and then you see the number going up again over the summer. And that really is representative of, once we filled those beds, having an issue with discharge following that, especially for elders, because, I think, as you know, during the pandemic, many, if not all of the nursing homes were closed to admissions at certain points of time, including Glencliff. So there was the elders that we had difficulty with discharging, but it was also during that period of time that community resources were limited due to the pandemic as well. So I think really, you can see the dip in the number again of increasing number of beds, but this climb represents the backdoor issue of discharge. And we're disappointed too. It was, one of my happiest days, that day in March where we had no one, and it just has crept up since then.
No, I appreciate that you're a midsection of the pipeline, that you have input issues into the pipeline and you have output issues with that pipeline to get people back into the communities. So, so this is not an easy problem. This is an entire statewide systemic problem. And I just hope the smart people are continuing to look at this to figure out how we're going to free up our emergency rooms. Emergency rooms have a purpose, and it's not to take care of boarding those with mental health issues. So.
Thank you. And I think what's most important for your committee to know is that, you know, with everything else that we do at the hospital, this is our #1 priority. This is it. This is what we work on every single day, trying to increase access.
Thank you. I don't see any other questions. You can continue.
Okay. So this next slide talks about New Hampshire hospital census trends over time. I think this also is a great slide because it shows our efforts in increasing just access for patients in the ED. So all of this growth in emergency room boarding is despite the hospital's effort to increase our capacity. The hospital did have an interruption in capacity due to COVID-19 quarantining protocols, but we've since then brought capacity back up to 100%, and we're operating with a census of 172 to 175 patients on any given day. So looking back in July of 2019, you can see average census was around 154. So we've really increased bed numbers by 20, essentially, and that directly correlates with the Hampstead contract. The dip that you see here in the fall, that was when we had our first cases, patient cases here at the hospital of COVID-19, and then we had to implement some quarantine and isolation procedures. So although 163 is the last number that's shown here on the slide, we're at 175. Today and pretty much every day. If we have a fluctuation of 1 or 2, it's really just due to patients being maybe evaluated in the emergency room for a medical issue. But other than that, we are maintaining 100% all the time.
So do you have a supply of vaccine, COVID vaccine, that you can use on your patients regardless of their other comorbidities and age? So that you're dealing with a vaccinated inpatient population?
Thank you for that question. We have been able to access vaccine for our patients that meet the requirement under 1B. So we have not yet gotten vaccine to vaccinate 100% of our patients, but we have received it for those that qualify under 1B. So in particular, our elders. So anyone over 65 on our elder care unit, but we do also have a number of patients just by the nature of their severe mental illness who also have a number of other medical conditions. So we started vaccinating patients 2 weeks ago, and we continue receiving vaccine and administering those in weekly clinics on our units.
Okay. Not being a clinician, I would just think that it would be beneficial if you could just 100% vaccinate new admissions, just because this is probably a more physical group of patients than other hospitals have, and that close interaction, it would be nice just to get that extra layer of protection for your employees.
I agree 100%. And I think that as more vaccine is received here in the state, I anticipate that we'll get there. And you're so right. You know, for our patients in particular, our patients that may be, you know, struggling with homelessness, they're really at risk. So definitely whatever vaccine we can get, we will administer.
All right. Okay, Representative Wallner has a question there.
Yes. Thank you. So recently I thought I had understood that 10 of the adult beds at New Hampshire Hospital had been converted once again to beds for children. So I'm wondering, one, if that is correct, and if it is correct, what did we provide for the 10? Is that just 10 more adults who now are in the emergency rooms? how is that working?
So yes, the way that that's working is we are temporarily accepting children again. And we anticipate that it will be short-term really into the spring around May. Child waitlist numbers had grown so dramatically that it was just not sustainable. The number of kids at a certain point, there were 50 children waiting in the ED. It was more than adults. So the quickest thing that we could do, and it's not the long-term solution by any means, but the quickest thing we could do was open up a kid unit again here at the hospital. So the day that we made that decision, we were again at 100% occupancy. Actually, we were over 100%. I think our census was 177 the day that we decided to open up the children's unit. We did have to temporarily stop adult admissions during that time, needed to work through some discharges. And right now our census is 165 adults and 10 children. We're accepting adult admissions again, but you are correct. 10 of those beds are offline for adults. So we have seen a slight increase in adults waiting in the ED as we work through this process, but it is planned to be temporary. And in the meantime, my understanding is that the department worked closely with other DRFs and hospitals to ask them to really take part in increasing access to adults during this time period so that we could try to minimize any negative effects on the adult wait list.
Thank you.
You have a follow-up? Your hand's up still.
Oh, I'm sorry. No, that answered my question. Thank you.
So I think what I heard in there, but just to make it explicit, is that you all have prioritized getting kids out of the ERs more quickly than the adults, and that's an active prioritization effort.
It was. That is correct. And you'll see in future slides that what's different about children during this time period is that although adult referrals had been fairly steady, what we've seen during the pandemic is that children's referrals have gone up significantly.
Thank you.
So I think this slide is a good summary of the situation for adults and referrals. So again, key takeaways, adult referrals have been steady. The wait list has grown. ED boarding has increased. Not only New Hampshire Hospital, but also the DRFs in private hospitals have been impacted by COVID-19. So at the same time during this pandemic that we have had periods of time where we had to initiate quarantine and reduce access, the same thing has been happening in hospitals. They've had some clusters of illness as well. So at this point, it doesn't seem like it's made a significant impact on the wait list, but the wait list has been growing really steadily over time. So you see some spikes with those quarantine time periods, but that's not really the primary reason for the wait list. I think, as you said, Chairman Edwards, this is a problem we've been struggling with for a while. On any given day, this is really important, the fifth bullet point. At least half of the patients at New Hampshire Hospital could be better served in a less restrictive environment.
So I don't want to start a long conversation here. I just want to do a checkpoint with you. Has anyone ever taken a look at a partnership between the Sununu Youth Center and the New Hampshire Hospital? I understand there's a lot of facility space over at Sununu that's basically mothballed. Kind of a yes or no. Have people investigated the feasibility of using some of that mothballed space? It's the Sununu Center.
And I haven't personally done that investigation or research, but my understanding is that the department has, and that it was not found realistic to utilize for inpatient care. That's my understanding.
Could you give me the bullet points of the summary of that that feasibility look?
Yep,
It
I can get
may
that.
not be formal, but I just would like to know the bullet points.
Sure.
Representative Wallner has a question.
On bullet number 5, what kinds of less restrictive environments have we worked towards during this past couple of years? I think did we do some work at the Philbrook Center and move some people from New Hampshire Hospital over to Philbrook? And what other kinds of work have we done to provide some less restrictive environments?
Yes, we did. We opened up a transitional housing program over at Philbrook. That's 16 beds. So that was a project that we worked on through the summer, and we opened that in September. And that program, and we'll get into detail of the program in another slide deck, but that's been very successful in helping us transition patients out of the hospital while they're looking for housing. Another area that we need more help with is just supported housing in the community along the lines of what NFI does. So NFI provides a great deal of structure and, in addition to the housing, and they have robust programming. They have an extensive wait list to get into NFI. So we struggle with the NFI wait list. For elders, people who may need assisted living level of care or nursing home level of care, that has also been a significant challenge that we've been working on. You'll hear more about that with the Glencliff presentation, but the other thing that we've been doing is doing outreach to nursing homes to see if they would become a partner to us in working with patients, considering patients who have psychiatric illness that have been stabilized at New Hampshire Hospital. So that's ongoing work that's happening to try to make a more robust system for these folks in the community. So those are the different pieces we've been trying to target. And you'll hear more about that when behavioral health does their presentation for you. I think maybe this afternoon or tomorrow. They have a lot of programming that they're working on as well.
Great. Could I have one? Yes, one follow-up. In the budget that we're looking at, the governor's proposed budget, is there funding in here for additional less restrictive housing for mental health patients?
Yes. Yes, there is. And there are RFPs that the department is pursuing even now.
Okay. Thank you.
Representative Nordgren.
Thank you very much. This is just a question. We got the briefing book from the department. So thank you, Karen. I was just wondering if Heather wanted to call our attention to anything that's in the briefing book. Were there any pages? I think the department starts on page 165, and I didn't know if there were any details in the briefing book that you would like us to be sure to notice. Thanks.
So
I'm just going to check with.
You're asking a broader question, Representative Nordgren. I want to check in with Mr. Ripple on this. We have, prior to the briefing book being available, we've gone through the slide deck and then we've gone into the Excel sheet. The briefing book adds another potential source of input. How should we do that? Should we be asking the presenters to hit the briefing book ideas as they go through the PowerPoint, or is that a separate conversation?
It has been done that way in past years. They've gone through the presentations and then the briefing book and then the actual accounts. I'm not sure if they're prepared to do that this time or not, though.
I don't want to put Ms. Moquin on the spot here. Are you up on what's in the briefing book? Are you ready to talk about that after you get through your slide deck?
Yes, I think that was our plan, was to go through the slide deck, and then I'm going to pass it over to Joe Caristi, our CFO, to get into more detail in the book, if that's okay.
Let me check. Representative Nordgren, is that acceptable to you?
That sounds like a good plan. Thank you.
All right.
Okay.
Other questions, keep going. Oh, NFI. You have to be careful with acronyms. NFI, what is that?
Oh gosh, you're putting me on the spot. NFI. I don't remember what that stands for. I'm sorry. But they have a number of contracted centers where they provide the transitional housing. So there is Concord, I think is the biggest program. So the Concord program, but there's also a couple of other locations in the state where they're doing the same thing.
You helped me by making it so I don't feel bad not knowing an NFI is.
I'm glad I could help you. I will look it up though. I should know that. So sort of the segue here into the question around adults versus children. So this slide shows the dramatic increase over time with child referrals. They have steadily increased through the summer and the fall. And what's important to know, and it's here in the bullet, but it doesn't take a significant increase in referrals to result in ED boarding. Over time, and we sort of touched on it when we were talking about days waiting versus number of individuals, it doesn't take that much of an increase to really stress the system. High referral volumes in subsequent months can cause significant capacity restraints. This is further exacerbated in facilities that are struggling to discharge during the COVID-19 pandemic. This has come up in particular at Hampstead with the discharge issue during the pandemic. So for children that are discharging home, not a problem, but for children who are in placement, in residential placement, in particular, if they are had an out-of-state placement planned or was current, there have been a lot of restrictions around kids moving around during the pandemic. So in particular, Vermont and Maine have had some pretty, serious, restrictions on children crossing the border. So placement has been difficult. Even in state residential placement has been challenging during the pandemic, and they've had some significant restrictions as well. So this has led kids to be waiting longer to discharge. So again, backdoor issue for Hampstead. That's what this is for kids waiting for placement.
So Representative Nordgren has a question.
Thank you very much. I don't know where to ask this question, but we did fund mobile units for psychiatry in the last budget. And I don't know, Kevin maybe can tell us if those are still in or where they went or what department what they would be. I'm not sure where they ended up or what happened, or if they even were used by the department. Thanks.
I'm not sure if the funds were spent on those mobile crisis units or not. I believe they would be in either behavioral health or children's behavioral health, most likely. I'm not sure if they were budgeted in the governor's budget or not, but that's something we can get to when we get to those presentations.
Okay, thank you.
No other questions?
So this slide shows the child wait list. And again, as referrals have increased, so has the wait list. And again, as a result, New Hampshire hospitals currently admitting children here as well as adults. We anticipate this ending in May. But you can see, I mean, these really are unprecedented numbers of children waiting. The other thing I want to mention is really for kids here in New Hampshire, this is really the impact, of isolation, the pandemic, different school systems. It's really incredible to look at. And over time, we've had seasonality to referrals. So, here, when we used to take care of kids here and also at Hampstead, typically during the summer vacation, referrals would just drop off. Very few kids getting referred. Same thing during the holidays or during school vacations, we would see a drop. that hasn't happened at all this year. There's no predicting this other than to say we see it go up and up and up with referrals. So I think it's important for us to acknowledge this. And I know certainly throughout the department and in children's behavioral health, what we're really thinking about and considering is, this is where we are now, but we're not out of this yet. And what will the long-term effects be over time for children and adults? I don't think we really know that yet, but you can see it's an area that's very stressed.
So where are these kids physically? Are they the ones that are on the wait list? Are they back home getting some wraparound services with their parents or parent, or are they sitting in an emergency room hallway somewhere? Where are they physically?
Mostly they're in the emergency room, but we have been working with children's behavioral health to have some kids go home with increased services and wraparound sort of crisis care in the home. That work is ongoing and I think increasing. I'm sure you'll hear more about that in future presentations. For some of the kids, though, they are waiting at home to return for an evaluation at Hampstead Hospital, but mostly they're in the ED.
See, again, I'm not a clinician, but I just can't imagine that to be good for kids. I just got to think they'd be better off with all of their problems at home than those same problems sitting in a hallway in an emergency room. So I see Mr. Norton's on the line. Maybe he can tell us later what he thinks. But hey, Representative Wallner has a question.
Thank you. I guess I'm just having a little trouble with understanding this slide. I see in, at least sometimes I can't quite read all these things. In October, it went up to 37 children in the wait list. And then what was this huge dip down here in December? And then it shot back up.
Yeah. So through the fall, Hampstead was working to increase beds. So they were actively hiring and bringing more beds online. So I think that that's what you see during that time period. They were able to increase admissions. And actually, I think we show that in a future slide that they've increased access and number of beds, as well as they've increased admissions, just period. Then at that point in December, where you see that, sort of that drop off there, and then that dramatic climb up, at that point they were full. And it's sort of this repeating pattern that you see here at New Hampshire Hospital. We put beds online, we fill them, and then we have trouble discharging. And I think that's represented in this slide, as well as just the ongoing increase in referrals.
Thank you. Could I have one follow-up?
Yes.
So does Hampstead have the ability now to start accepting more children?
At this point, there are 7 beds that are physically present at Hampstead, but not staffed. So that's where we were talking about. We think that in May, New Hampshire Hospital will be able to step out of that because they have a provider returning from a maternity leave in May. So that'll open up an additional 7 beds. The other thing that is, I think, it's fluid, as far as occupancy goes for children, is that for kids, some kids can't be in a shared room or a semi-private. So for a number of reasons. So that can impact Hampstead's ability to admit. They do have a number, not all their rooms are private. Many of them are semi-privates. So that is also just related to acuity. That's some of another thing that they struggle with for keeping kids safe. But and it's another reason that some kids wait a little bit longer in the ED because they specifically need a private room.
Thank you.
Sure.
And then Representative Wallner, you've earned the right to just ask your questions without having to ask for a follow-up. I won't stop you unless it's gone too far, but I don't think you'll do that. So you're welcome to have a natural conversation.
Thank you.
So go ahead.
So this is the slide that shows their total number of admissions. So you can see they started increasing actually back in July of 2019. You see the point in February where we executed the contract. You see the increase there to 108 in March when we rapidly, started utilizing the contract. The drop off that you see in admissions there, I think that represents that initial lull in referrals. And I think maybe you all remember at the beginning of it seems like forever ago, but a year ago when this all started, people weren't going to the ED at all. So we saw a big drop off in referrals at the very beginning of the pandemic. Everybody sort of hunkered down and stayed home. We saw the same thing at New Hampshire Hospital with adults. Referrals dropped, but then they picked up again to the current level that you see right now.
Representative Wallner, your hand is up. Is that from the previous conversation? Okay. Sorry.
So, in summary, we do think that Hampstead has done a great job expanding their capacity and accepting more and more children. So this is the summary just regarding children. Again, Hampstead has steadily increased capacity, but they've seen at the same time an increase in demand. 3 of the past 4 months have had higher referral rates than the preceding spring or summer, so comparing year over year. And Hampstead is accepting a comparable, if not more, referrals than New Hampshire Hospital ever did. So that sort of speaks to referrals that convert to admissions. So this last 3 bullets are sort of, I already said this. So this idea that some kids require the single room, so that can impact capacity. They're having trouble with kids waiting longer for placement. And COVID-19 and quarantine issues have been difficult with staffing, as they have at New Hampshire Hospital. That seems much better, both here at New Hampshire Hospital and also at Hampstead.
So if I were helping write this slide, I would add another bullet about kind of a unacceptable level of pediatric wait list hanging out in emergency rooms instead of at home with wraparound services or an admission. I mean, I think that's a major part of this summary of where we're at, and we need to focus on that.
It really is, and that's the reason we started bringing kids back here. It's just such a crisis and such an issue for these kids. So, key accomplishments and challenges for New Hampshire Hospital. We've had a busy year. We've been working on a lot. And circling back to our strategic planning and metrics, we've been able to accomplish a slew of targeted solutions to improve performance relative to our metrics. We opened the PATH Center, the Philbrook Adult Transitional Housing Center, which we'll discuss more in the next presentation. We executed the contract with Hampstead Hospital for pediatric care. We've drastically improved our ability to recruit and retain staff. We've increased census at New Hampshire Hospital. We've invested in crisis prevention training that has reduced employee injuries. And we've implemented a new form of billing for professional services that has helped offset some revenue shortfalls that came from contracting for pediatric care. Oh, I want to just highlight one other thing that may be of interest. We did a staff vaccine implementation that we started in December. And at this point, about 80% of our staff have received both doses of COVID-19 vaccine. That has dramatically improved our staffing, reduced illness. It's really been amazing. So I think that was a huge accomplishment for us. And I'm really proud of our staff who were proactive and wanted to receive vaccine.
20% remaining, are almost all of them people who've refused the vaccine?
Yes, we have had, since we did our program, we have had a few people change their mind about receiving vaccine, and we've helped them to register at a fixed site to get their vaccine. And in addition to that, new staff, we're working that into our orientation to help them get their vaccine. So I would anticipate our numbers will increase.
Are you anticipating a need for incentives to vaccinate or coercion to vaccinate? Or are you going to accept that some employees don't want the vaccination?
I think we will continue to educate. And I think that over time, as people see coworkers receiving vaccine and they receive more information about how safe the vaccine is, like I said, we continue to have people change their mind and convert over. So I don't think that we will need to incentivize. There is a group of employees who just absolutely are adamant that they will not be forced to receive the vaccine. And, that's okay. We keep educating, but they have very strong feelings. I'll say that.
Thank you. Representative Nordgren, you're not muted. Okay, thank you. I appreciate the answer. I'm anti-coercion.
Good. So these key accomplishments are here on the timeline that you see in front of you. What we're most proud of is that we were able to achieve all of these accomplishments despite having to react and respond to COVID-19 and the numerous challenges that it represented. This is an absolute testament to the dedication of our New Hampshire hospital staff. It's been nothing short of humbling to be part of this hospital during this period of time. I'm just very proud of all these ongoing efforts that we've made. So in summary, you see our key challenges here. Front door for both adults and kids. Back door, and those details are listed. And then our operational and financial challenges are listed here. In regards to the challenges the hospital has, you've seen that those three categories. Everyone knows about the publicized challenge in the issue of emergency room boarding of children and adults. And as you said, Chairman, it's not a new problem. This has been an issue with meeting demand for years. We continue to operate at full capacity on a daily basis. Through many conversations and analysis of data, we've come to realize that a portion of our front door challenges are actually caused by the back door challenges that we've talked about. For fiscal year 2020, nearly half of the patients at New Hampshire Hospital no longer required acute inpatient care, but the community resources necessary to safely discharge them are limited. As a result, the hospital's lack of ability to discharge contributes directly to the front door issue of not being able to admit. Lastly, the hospital faces numerous operational challenges relative to recruitment and retention. We have furniture that no longer meets infection control standards and an aging building that doesn't meet new infection control standards. These are challenges we've been working diligently on, such as executing new contracts to aid in staff recruitment. And we're currently underway with a $4 million renovation that was approved as part of last biennium's budget.
So, question here is,
Yeah.
do you already have an alternative process in place to where front door admission requests are evaluated to determine if they could pass directly to go without coming through the New Hampshire hospital? In other words, that they're awaiting admission, but maybe it's possible to just bypass admission and get them straight back into the community?
Thank you. That's a great question. We do. We have what we call our admission huddle. And that happens at least twice a week, if not more. And during that meeting, we have a group that includes our medical director, Jeff Fetter, myself, social work, our admission staff. We go through every referral that has been received here at the hospital, and we talk about alternatives. Could they go to a DRF? Could they go to a voluntary unit? Sometimes we have Jeff reach out and speak with the clinician at the hospital and make recommendations to initiate treatment and maybe avoid the hospital visit. Some of the referrals that we have, and these are folks that are boarding, are substance use disorder primarily. And so, we review those cases and again, talk through with the hospital what an appropriate referral would be, because, for those folks, it's not obviously not appropriate for them to come here. But, based on sometimes behavior or people being under the influence, we do get those referrals. So yeah, we try to be really timely in making recommendations and declining admissions if it's appropriate.
Thank you.
So moving on to benchmarks. So this slide really talks about, how we figure out care basically, and how to calculate the work that we do. So while staffing specific benchmarks in inpatient psychiatry are really highly contextual, we do benchmarks ourselves on a cost per day, which we felt was the best way to sort of show a good metric in terms of our cost effectiveness or stewardship. So that's
Like
what this shows.
I like this slide a lot. I just would ask, is that a government-owned hospital? Is that government-owned psychiatric hospitals?
Yes, it is.
Are there any questions here from the committee? No. So if we were to fund you at the average,
Mhm.
that would be lots of millions of dollars, wouldn't it?
Yes. I think this really shows how lean we
Yeah,
operate.
I'd be curious, and just a rough order of magnitude estimate of what additional incremental money would be needed just to bring you up to average from the governor's budget.
We can calculate that.
It doesn't need to be hard math, just
Mhm.
something close.
To average. Okay, I'll get back to you.
Representative Wallner?
Thank you. Did the governor's budget fund you at the level you requested? And if so, did you have other prioritized needs that were either funded or not funded?
Yes, we were approved for what we asked for, and I'll actually defer to Joe Caristi to speak in more detail.
Sure. So good morning, everyone. Can you hear me okay? Okay. So yes, the budget that was requested was funded. When we go through the financials, there are two things that we want to bring to your attention today. One of them was kind of an item that came up in the final days, if not, I think the final day of trying to finalize the budget. So it wasn't so much that it wasn't funded, it just was one of those things that was really hard to time and get built into the governor's budget. So I will talk about that in a bit more detail in a few minutes here. But yes, what was requested has been funded.
Great. Thank you.
So this next slide is the slide that talks about, what if we got an increase, 5%, and what if there was a decrease? Most importantly, I think that a 5% decrease, the number one thing you need to know is that we would have to decrease capacity. That's the only way that we could manage that. That would involve potentially layoffs and hamper our ability to meet regulatory standards. We are Joint Commission certified, so that would be very difficult. If we got
Any
more
problems? Do you have
big
any
problems.
problems currently? Do you have any problems currently with your JCAHO certification?
No, not currently. We're anticipating that they will come back for our review sometime in the summer or fall. It's hard. They have gotten very much behind in their survey and their reviews because of the pandemic. But we are anticipating that they'll come over the next year. And you can see on the slide, you know, what could we do if we got an increase?
So it's
There-
not good. It's obviously not good to not pass a JCHO certification. But what happens to you if you didn't pass that? Do you lose federal money? Do you, I mean, what?
Yeah.
I'm not encouraging it. I'm just asking what's the worst case here?
I can jump in here a little bit, Heather, if you'd like.
Thank you.
From a financial perspective, CMS does reserve the right to stop paying all Medicare claims. I believe they can also expand that to include Medicaid claims as well. So there's a significant financial impact. And then I believe they also, just from a oversight perspective, can pause things like admissions to the hospital and so forth until issues are resolved.
Okay, thank you. Just to summarize, I'm not encouraging it.
So this next slide talks about our staffing patterns, number of positions, and then the percent of total positions. I think that this is a great slide because it really shows how lean we function, really. You can see that our direct care staff represent, 73% of our budgeted positions. So we have very few administrative staff. And then support services, I think, is really in range of, industry standards, if not a little low. Again, we get a lot done with a little. So
Members of the committee have asked on these questions what your vacancy rate is.
that's a great question. Vacancy rate for mental health workers is around 22, 23%. Vacancy rate for RNs is substantially worse. That is around 30%.
And you're trying to make that up with per diems and just overtime?
Per diems, overtime, travel nurses when we can get them, but it's we're in the same workforce struggle that many hospitals are in right now, with the nursing shortage and the effects of COVID-19. So it's very difficult.
Do you think you have very many support services people who have been sucked into doing administrative work instead and just aren't listed as administrators?
No, I don't think so. I think, and Joe, jump in if I'm not correct, but these support services staff represent materials management, food and nutrition, environmental services, facility staff. So I don't think that there's sort of overflow into admin.
The only thing I might add to that, our financial team, so our revenue cycle and our accounting teams are included in that support services category. One could argue that those are a bit more administrative in nature, but still required functions of the hospital nonetheless.
Sure, but your actual hands-on clinical people are all in the acute psychiatric services line, and that's got about a 30% vacancy?
Correct. So next up is the financial summary. And Joe, maybe you want to talk a little bit about this slide.
Sure. So just to provide some context on these graphs, in the 2018-2019 biennium, the hospital collected a portion of its revenue called DISH, disproportionate share payments. We use an acronym called DISH to refer to those. The hospital received those DISH funds as federal income. And the DISH fund program is a program managed by CMS, and it's really intended to reimburse uncompensated care. So New Hampshire Hospital is the largest consumer of DISH funds in the state. We have the most uncompensated care. And so in that biennium, those were logged as federal funds. In the 2020-2021 biennium, those funds were changed in how the department managed them. So in the 2018-19 biennium, New Hampshire Hospital was unique in how the state paid its dish funds to New Hampshire Hospital versus how those funds were paid out to every other hospital in the state. In the 2020-2021 biennium, we made it the same. So now every hospital in the state receives their dish payments the same way. And so that's really just resulted in now Medicaid draws down the federal funds, and then they pay them as other revenue to New Hampshire Hospital. So I just wanted to highlight that because it looks like a very significant change in the proportion of federal funding between those 2 years, but it's really just a change in definition almost. So you'll see that the general fund percentages remain relatively the same between those 2 years, and then the total of federal funds and other funds from the 2018-2019 biennium are pretty comparable to the total funds in the 2020-2021 biennium. The federal funds in the 2020-21 biennium that are still there, so that, you know, the 3.8 million, that was CARES Act money that was paid directly to the hospital. So these are not gopher funds. These are what are called provider relief funds. They were paid directly to every single hospital through their billing exchanges, essentially. And it's really aimed at helping hospitals pay for PPE, helping them pay for costs associated with screening services, testing services, treating individuals with COVID-19, buying new pieces of equipment, or improving their facility or their environment of care to meet a higher level of infection control. And so that's what that little sliver of federal funds is in the current biennium. In
I have a
the
question.
Sure.
Are we going to have an opportunity to use any federal COVID money for infection control to replace some of that furniture?
That is a great question. So we actually have a couple of projects underway. And to answer your question, yes, we've already replaced certain types of furniture and bought certain pieces of equipment. As an example, we bought a UV light machine that we can stick in a room and essentially decontaminate a room in a matter of minutes, which has been really helpful. But we also have two projects we're working towards. One is putting UV light equipment in our air handler system. And then one is also working to remove fomite surfaces on units. So that would be things like carpet, you know, anything that is not anything that is a permeable barrier, I guess is a good way to phrase it. So we do intend on spending, quite frankly, a majority of those funds on improving our environment of care for infection control standards.
Okay, try to replace that furniture. Hey, Representative Weiler has a question. Your hand, you're there you go.
I'm unmuted. Thank you, Mr. Chair. There's a sizable increase for the next biennium in general funds that we don't have. It's like 12, 13% increase. Why is it so sudden?
Sure. So the primary increases in general funding is relative to positions. So a portion of it is wage increases that are scheduled. And then another portion of it is 30 new positions to help us increase census on the former children's unit. So we have 30 new positions that we created in this current year. We're actively recruiting to fill them. We requested to have those converted into permanent positions in the upcoming biennium. I believe that the governor included those conversions in his version of the budget. And so those are the primary drivers of increasing general funds. We did not ask for you know, more equipment money or more supply money or facility type maintenance expenses. It really pertains to staffing.
Well, we're finding that throughout the HHS, and we just don't have the revenue to sustain it, what we're seeing as requests. Thank you.
So follow-up I have on that is I don't understand the logic behind creating new positions or converting positions to permanent if we have a 30% vacancy in the clinical care area anyways. If you can't fill what we got, what is the point of adding more FTE spaces if you can't hire the faces to begin with?
So I think that's a wonderful question. As Heather has alluded to, we've worked really hard to try to increase our recruitment and retention practices. Part of that were actually 2 items that were approved in, it was either the last GNC of November or the first GNC in December, relative to a wage enhancement for mental health workers, which I'm going to talk about a little bit more in a few slides here, but also some new ways of recruiting staff. So we've executed a temporary to permanent staffing contract with a staffing agency. So these individuals come to us on a 9-month temporary basis, and after which they would, hopefully, assuming they do a good job, they would apply for one of our positions and we would hire them into that. That contract has seen pretty remarkable success up to this point. So I believe we've hired 24 individuals through that process since December. That's a great leap for the hospital. And we're going to continue trying to find creative and alternative ways to fill the positions. So I think your point is certainly spot on of, do you need to increase positions if you can't fill the ones you have? But I do think we have quite a few efforts and plans in place to try to fill the ones that we have and make sure that we can fill the new ones as well.
Okay, I'll take that. Representative Nordgren, it looked like maybe you were trying to raise your hand when you were touching your computer. No?
No, I wasn't.
Okay, I just didn't want to miss you. All right.
So there are 2 specific challenges that we wanted to bring to your attention relative to the hospital. So the first is relative to those DISH funds I mentioned. So again, this is a CMS managed program to reimburse uncompensated care. In December of this past year, CMS redefined the formula for calculating uncompensated care in a way that will most likely negatively impact the hospital's revenues. The new calculation essentially excludes a population of data that we were previously including. So there's no issue with prior years. We've confirmed that issue, but we have some pretty significant and complex outstanding questions that we're seeking CMS technical guidance on. Depending on the answer to those questions, this could be a couple $1 million revenue change or a much higher revenue change. So we just wanted to point this out and bring it to your attention. I don't anticipate having those answers from CMS during the House phase, so we will likely be making a change request in the Senate phase, but we felt it was important to bring to your attention. Again, this is a program we don't have any control over, and it's probably also worth noting that although this is a significant revenue stream for the hospital, this is a program that's been under continual threat of discontinuation at the federal level. So it's been proposed quite a few times to start the process of reducing the amount of DISH paid at a federal level. And there's even been kind of schedules that are intended to bring it back down to 0 and discontinue the program altogether. So from a financial perspective, this is kind of a high risk area for us over the next probably 5 to 10 years. But this recent change in legislation will definitely impact us in the upcoming biennium. And once we have those firm answers, we'll be able to come up with a firm number and make an appropriate change request.
So because we have to do a markup, what is a reasonable, in your opinion, a reasonable contingency risk reserve for this? 5 million?
I would say, yes, yeah. At a minimum, I think it will be 2 million. That upper end is it's really tricky because the questions we're asking really change the scope of that population. Our DISH consultants have the same interpretation of the federal law change that I do, but without that specific CMS guidance, I'm a little hesitant, as you can probably tell, to give a hard number.
Yeah, no, I can tell, and that's 5 million a year.
Yes, yep.
So, Mr. Ripple, would you kind of keep track of that? Because as we're talking about finding money, that we may want to have a plan for that as well.
Yeah, sure, I will.
Thank you, sir.
You want to go to
Slide.
Yep. So the second challenge we wanted to bring you
Before
your
you get
attention.
going again, before you get going, Representative Weiler has his hand up. Is that from the last time?
No, it's a new question. What about collecting money from private insurance or from the people that are admitted from themselves? Is there any money in this that's coming from those people or from insurance? Thank you.
That's a great question. So we do have a contract executed with Blue Cross Blue Shield, and contracting as a hospital with commercial insurance carriers is a very common practice. So Blue Cross Blue Shield is currently the only contractor or insurance carrier we have a contract with. We have attempted to contract with a lot of other insurance carriers. We have not been overly successful in that, and I think there's a few reasons there. So one is a lot of the insurance carriers have very few patients that come through our building. So what we do in those scenarios is what's called a single case agreement, where we call up the insurance company, we come to an agreement for the specific admission that is in question, and then we receive payment accordingly. About 21% of the hospital's patients have some form of commercial insurance. When it comes to contracting with insurance companies, that's been an ongoing challenge. It is something that I've been researching pretty hard in the past couple of months. I'm trying to find more definitive ways to make sure we can execute these contracts. It's been a concern of mine as I've oriented to the organization. So we're definitely going to try. I think it's not something we can readily plan for at this point. We've had almost 8 months now of negotiation with Optum. We've approached Harvard Pilgrim in the past. We've approached Cigna. It's really just challenging to get these organizations to sign an agreement with us. And if I'm being 100% honest, I think part of it is because we're a safety net hospital, and we're not going to turn anybody away because of their insurance. So I am actively working on trying to find ways to tighten that up a bit, but it's not a clear-cut solution, or there isn't a clear-cut solution, I guess I should say.
I don't think we can afford to giving away free care when we're one of the wealthier states. If these people have something we could attach or collect money from, whether it's property or whatever, rather than just keep giving away and keep expanding the tax costs to the people that are not using these. We've got to do something. Thank you.
I should also just share that we do so we do what's called a financial eligibility assessment on every single patient that enters the hospital. We do essentially a resource check to see what they have for available funds, and if they do have a significant amount of wealth, whether that be property, income, savings accounts, etc. We do work with the patient and or their guardian to make payment for the services that they receive. So we do collect self-pay type payments from any patient who has the ability to do so.
I didn't see a self-pay wedge in the revenue bubble, though.
So that is considered a part of our other revenue. I can certainly provide on our billing revenue side, I could provide you a percentage breakdown of how much comes from Medicaid, how much comes from commercial insurance, how much comes from self-pay. If you'd like that, that would not be a problem.
I'm just thinking about the slide you showing in the FY 22-23, and there was no wedge for self-pay. And so I'm just wondering if it was overlooked or assumed to be part of something else.
It's a part of other revenues on that graph.
There's no other revenue there, is there? I don't recall in the 22-23 seeing another wedge.
So if you want to go back, Heather. So in the 22-23 pie chart here, the blue section is other revenue. And so that consists of
Oh, geez, I thought, okay, so that's my fault. I thought that was all federal. No,
no,
I misheard when I saw this slide. I apologize for the interruption because I assumed that was red was state and blue was federal, and that's obviously a horrible assumption.
not a problem. Okay, so so moving on to the second concern we wanted to bring up to your attention today. So in that last GNC, and I think it was either November or the first one in December, as I had mentioned before, the hospital had brought forth a mental health worker pay enhancement, and this was really a vehicle or a tool and a series of efforts to try to improve emergency room boarding. So the hospitals, as you mentioned, we struggle with recruitment and retention. We have a high vacancy rate. We're trying to find ways to close that gap. And so one of the ways that we felt we might be able to do that was with a pay enhancement for mental health workers. Mental health workers are frontline staff. They're the ones who really operate on the units on a day-to-day basis with all of the patients. They provide assistance doing a lot of daily activities. They perform a lot of safety functions, safety checks and regulatory governed functions. And they're really just the frontline staff for the hospital. An issue that we've come to find is that the wages that we've been paying, we really compete with, I would say, less hazardous or potentially easier type positions out in the community. So before this enhancement took place, mental health workers were earning between $12 to $13 an hour, kind of starting out. After a few years, they might make a comparable wage to a fast food worker in the Concord area. And so, we're really struggling to recruit at that level, knowing that there are some of these other positions out there in the community that people could achieve.
So I assume you're talking about LNAs, not RNs.
Actually, we're not even talking about LNAs in this instance. So these are unlicensed individuals. Some of them do have LNA licenses, but you do not need a license to be a mental health worker. So they don't do a lot of medical type care. They do. Oh, sorry.
I just wanted to understand what that $12 to $13 was. That's pre-LNA for the most part.
Correct.
And then are you offering those people any sort of education benefits so that they start moving up the LNA RN path?
Go ahead.
Yeah, I can take that question. So yes, what happens when we hire a mental health worker, if they are a person that has not had experience, it's multiple weeks of training really in psychiatric care. So it's not really an equivalent to an LNA's, scope of practice. So an LNA provides, hands-on care, medical care, vital signs, things like that. Mental health worker needs to be trained on how to react in a psychiatric crisis, how to have a therapeutic relationship, how to ensure safety of patients and staff, because it can be a pretty intense environment here for someone who's not, stable psychiatrically, particularly on admission. So they receive all of that training. Once they are employees here, we absolutely work with them. Many of them go on to pursue nursing licenses, particularly RN, psychiatric nurse licensure for sure. So that is something that we have been working on. So, this enhancement really was part of not only attracting new staff, but retaining the staff that we had, because we, found that we, invested all of this time in training for these mental health workers in a very specific role. And then they were leaving to go, work in an environment that was easier, whether it's Target or Walmart.
Yeah, so that's kind of why I like the idea of an educational benefit that gives them golden handcuffs to stay for a few years after achieving their RN or something.
Yeah, another thing that we're working on, actually Chuck Bagley is our staff engagement director, and we are developing an LNA program and a curriculum that we will run here at the hospital. In addition to that, we're doing a lot of outreach with nursing programs to see what creative solutions we can come up with to have it be to their benefit and to ours to get folks through nursing school. So it's a big priority.
I would just mention that as far as tuition reimbursement, the department does offer some tuition reimbursement that is budgeted within the human resources budget for the whole department, which is something that we covered in the Office of the Commissioner. There was several $100,000 in a training line that was training for employees, and that is where we would reimburse for tuition from, and that goes through Governor and Council.
I hope that they incur an obligation period after accepting the money. Whether we can enforce it or not, I hope we're at least asking for a couple, 3 years after they receive the money to stay.
I don't recall, but we could get you that information.
All right. Go ahead. I'm sorry, I interrupted you, Joe.
Oh, no problem. It's a great question. So this was approved, recently, and so once it was approved, we worked really hard to get it built into the payroll system of the state, and then we started working to get it built into the budget system, and that process took a lot longer than I think we would have liked. So there was some interesting questions that came up of, does the 20% apply to just base pay? Does it apply to base pay plus shift differential? We had to sort through some of those nuances. And so by the time we really got this built in for every single position into the budget system, what really ended up happening was we ran out of days or time in the governor's phase. So we were able to get it built in, but when we finally got it in, it put us over the general fund target we were shooting for. So given that we transition it to be 100% other funded to keep the total budget request in line with the hospital's needs. But the challenge here is the hospital doesn't have the ability to earn more revenue because it's incurred this cost. And so, we really, tying this back to trying to increase our ability to respond to the emergency room boarding crisis, to increase census, we need to increase staffing. To increase staffing, we need to improve recruitment and retention. And so that's really the kind of the cornerstone of where this idea came from. In the 2021 budget, I do want to emphasize, so because we had some vacancies for the 6 months prior to this being approved, the department felt confident that we could try to fund the rest of fiscal year 21 for this enhancement. And so we have. So this is something currently being paid. But we don't anticipate those vacancy dollars being available in the upcoming biennium, again, because we're taking such an aggressive approach towards recruitment and retention, and we're seeing some successes in terms of that temp to permanent staffing contract we've executed. So.
So does it seem to me like you're wanting to tell us a dollar amount that we need to anticipate being added as part of this change request?
Yes. Would you mind going to the next slide? So
I hate to ruin the surprise and the secret, but.
No, I appreciate that. So these are the numbers for each year of the biennium. I certainly understand these are pretty significant numbers, especially in the context of your opening remarks, Chairman, relative to goals for the House budget. So, but these are the amounts as it stands based off the number of positions we have and the positions that the enhancement would apply to.
Okay, so far it's feeling to me like we need to be thinking about $20 million more over the 2 years for the hospital that are not in the general funds budget. So that's a significant amount of money for us to look for. Representative Waller, you had your hand up. I kept talking. Do you have a question, ma'am?
No, this slide answered my question. Thank you.
Okay, well, that's like real money. So if we could get your help looking for it, I'd appreciate it.
Certainly, I think, I've scrutinized this ad nauseum with my team. We're going to continue to scrutinize it to try to see if there are any opportunities. But we've done quite an extensive dive at this point, and so ultimately this was the number in the slide that I felt I had to present today. So
Yep, I appreciate that.
sure. So then in terms of our accounting units, so these are our accounting units. The first one listed here, 6096, is actually going to be reviewed in a separate presentation. We created a presentation just for the Path Center, knowing that it's a new program, and we thought it would just be helpful to give you some extra context on that. The remainder of these are all accounting units for the hospital. And so, Chairman, would you like me to open the budget book or the briefing book first?
I hit the budget book first.
Okay. Heather, do you want to stop screen sharing for a second?
So Mr. Ripple, before he continues, how do you think we're doing on time? You see the big picture there. Are we behind schedule at this point? It feels to me like I'm running this a little
You good?
long.
I think possibly you do have 3 more presentations after this, I think.
That is correct. The next 2 that Heather and I will be presenting, I do think will be shorter. The Path Center certainly will be shorter.
I would like to be done.
Probably.
I would like to be done by 3 o'clock. I don't know. I'm looking at everyone's faces on Zoom. I'm not seeing anyone freak out when I say 3 o'clock. So, let's go.
Okay. All right.
You're not going to go through all 1,374 pages of this.
I am not. Oh, I'm sorry. This is the briefing book. 1 second.
You know, while you're getting ready there, we've been talking for almost 2 hours. I'm thinking maybe the committee and the attendees could use a 5-minute bio break, 5-10 minute bio break. So why don't you, Mr. Christie, get ready, and then we'll come back. I have us at 11:23. We'll come back at exactly 11:30 after a bio break.
Okay, sounds
All
great.
right. So I don't know, Mr. Ripple, if you have to put a recess sign up or something.
Sure, I'll put a sign up.
Kevin, I believe Heather and I are just going to run to the restroom as well.
Okay.
All right, it's 11:30. Do we have the committee back? I feel like romper room. I see Keith. I see Mary Jane. I see Harry. Okay, I think we have a quorum. So
We don't
please.
see you.
Oh, you don't? Hopefully I don't have anything in my teeth. That was a pretty quick sandwich. All right, Mr. Christie, you're up.
Okay. So I'm sharing the budget document now. Really starting at the accounting units relative to the presentation we just had would be starting with 8,400 here. I'm happy to answer any questions you might have.
So I think you've explained in the slide deck why expenses 10 and 12 are going up in the biennium by a significant amount.
Correct. It's in the accounting unit 8,400, that is solely because of increases, scheduled increases in wages.
But wouldn't that mean that overtime might be less if you're successful?
So it's somewhat depending on the, I would say, accounting unit, but so in 8,400, for example, this is administrative staff who are just receiving essentially a step increase in their pay. So it's a higher cost for the same amount of hours worked. And then in other sections, so 8,750, which is really our direct care accounting unit, that's where the significant increase is represented from a payroll perspective. And that's driven by both increases in wages, but also increases in position counts.
Yeah, I'm sorry. So it took me just a moment to get my head into the right space here. So you're only adding one FTE on your permanent classified, but you're driving your personnel costs up substantially in the biennium for the one extra person plus step increases. So and we're talking about 8,400 admin, right?
Joe, if I can just add there, I believe that there were unfunded positions in 20 and 21, which are now funded in 22 and 23. So I believe that's also part of that increase is some previously unfunded positions.
Okay, do you want to move us back to that slide? Go back one?
Sure.
Because that's where it is. That's where the money is with the
Yes.
one increase.
Yep.
It's
All
those
right,
unfunded positions.
So I'm going to let Mr. Ripple speak first, and then Representative Wallner had her hand up, and Weiler and Nordgren.
Thanks. The one thing I wanted to point out that you will see agency-wide and budget-wide is personnel costs in 22 might appear somewhat high because there are 27 pay periods instead of 26 pay periods that year.
That explains part of it. All right. So Representative, was that it, Mr. Ripple? That's a good add.
Yes.
Thank you. Representative Wallner.
Thank you. So the 20% increase in wages, probably that you say we might need to anticipate, it would not affect this page. Is that correct?
So that's correct. The total value for that pay enhancement is built into this budget. It's more of a source of funds issue. So it's currently funded as 100% other revenue sources, not general funds. And the challenge there is we can't earn that money. Yeah, we don't have an ability to earn that money.
Okay, thank you. Thank you.
Representative Weiler.
Thank you. I see that the class 10 went down in 2021. I assume that's because of vacancies. And you say you're trying to recruit, and so you're going forward, you're assuming full membership or full positions. I don't think we can assume that. We can't afford it. So I wouldn't be so quick to, if you can operate with reduced personnel, then you've got to continue that, because we cannot afford a 15, 20% increase, which you're showing here. There's no way. Unless you're going to go out, get some money from somewhere else. Thank you.
I certainly understand that. I think I think the thought process is, or for at least for us, we're really trying to make some fundamental changes to emergency room boarding, and we feel that some of these changes would be the things we need to really try to start making a dent in that.
So that might be really a good thing for us to go over after we get out of the heat of battle on the budget. You know, where we have a little bit more time to reflect on the big plans. Representative Waller, your hand is still up. Did you have a question still?
No, I just keep forgetting to put it down. Sorry.
No problem. Representative Nordgren, you had your hand up and yours is down now. So do you have a question? Representative Nordgren? Well, we may have lost her altogether because she was there with her hand up and now I don't see her or hear her. Okay.
I'm here. I don't have my hand up.
Oh, okay. All right. Put your hand up anytime. So the other thing that jumps out here is expense 060 benefits. And I think what you're going to tell me is that this is a fixed percentage that you're given by somebody else and you have to apply it to your 10 and 18 line or something.
Yep, that's correct. It's a fixed percentage based off class 10, 18, 19, and 59 if there was one. But yes, that's a percentage given to us by the Department of Administrative Services. And I believe I tuned into a prior presentation, and I know this is a question that came up. These numbers do look consistent with historical amounts for the hospital.
Okay. I don't see any other questions if you want to continue.
Okay. So 8410 is really our supportive services accounting unit. So that, you know, environmental services, our facilities teams, our food and nutrition department, our finance team I mentioned earlier. Again, increases really being relative to payroll. It kind of in a general synopsis of the hospital's budget, you know, I think we mentioned before that you know, 72% of our staff are direct care, but I think proportionally just the payroll to other lines of the budget is quite high. So we didn't budget any more for equipment. We didn't budget any more for supplies. We kept all of those flat. And some of them, you know, some of the other expenses we work hard to try to either reduce or at least keep them flat.
So I see the food institution money. Is there, should I be seeing a furniture line here?
So that is actually in 8400. So this class 30 equipment line right here, that is relative to any equipment or furniture for the hospital. And this value comprises the hospital's entire equipment and furniture budget.
Okay, and what does that represent? 10% replacement, 5% replacement, 100?
I would say, off the top of my head, I would say less than 5%. So it's pretty challenging. Most of our replacements year over year are when things are hitting the end of useful life. We're not, and there are quite a few pieces of equipment we drag out beyond the manufacturer's, you know, stated use of life, so long as it keeps functioning and it's properly serviced by a biomedical engineering service. And
then I'm looking back at 8410, and there's such a tiny amount for 037 technology hardware.
Yep.
That I wonder if that's kind of a mistake, if that's supposed to be in somebody else's budget and accidentally ended up here.
So I'm not 100%. I can't recall exactly how we arrived at that number. Class 38 and 37 are two new lines to New Hampshire Hospital's budget. We used to charge these, I believe, to class 30 or class 20, depending on the dollar amount. And we felt that these classes offered a greater specificity on some of the items we were buying, so we included them in this upcoming budget.
Sure. I'm just saying it looks like it's either a mistake or it's not enough money.
I would agree. I think I think it's the latter. I think it's not enough money, but I think that's because we wanted to just create the class line, but also know that we were trying to keep things relatively flat outside of our payroll increases.
In the telecommunications, you spend that with DOIT, or do you have direct contracts?
That is really through DOIT. I would say I still think it's a DOIT service though, but you know, cable and internet and things like that in the building. I believe that's the majority of that line.
All right, well, thank you. I see Representative Erf with a question here.
What is the transfer to other state agencies?
Great question. So the state office, campus police department. So at New Hampshire Hospital, the state office police department is actually housed inside our hospital, and we require their services on occasion in working with some of our patients. So this is really for the cost of that police department. And so that's a transfer to the Department of Safety.
Okay. Wow.
How do you measure service provided or service requested for this line? Do you have a measure, or is that just a number that you all agree on?
And Heather, jump in here if I misspeak, but I believe we really try to maintain at least 2 officers on site at all times, really for safety reasons. So, you know, in scenarios where an individual might escalate to a point where we require their assistance, we really try to have at least 2 people on site 24/7.
Yeah, I would agree with that. We do have a dispatch person that's also part of that, but that's really very necessary at night, in particular when we don't have receptionists on duty. That dispatch person handles emergency calls from the units and relays that to the officers. So yes.
Very good. People need to be safe. All right, thank you. There's another question by Representative Erf.
No, my bad. I should take my hand down. Sorry.
Okay. All right, you can continue.
Okay. So 8750 again is really where all of our direct care costs are incurred. Again, the majority of this increase is relative to payroll. Happy to take any questions.
Yeah, so I think one of the consequences of putting plussing up the 30 in the permanent classified is that it's increasing your 010 expense line, and I still don't quite get your logic on why you're creating 30 more spaces when you can't fill the 438 you already have. I don't get it. And if that shouldn't be done, that would lower the 010 personal services line in a way that doesn't hurt anything.
That is correct. I think our logic behind those 30 positions is that we intend to fill them, and we are actively changing the rate in which we are able to recruit. And we're actually, I would say, not just hoping, we're seeing results in that that realm as well. So again, between just December and now, we've hired 24 new mental health workers through a temp to permanent contract that we've executed, and that's a significant increase. You know, at the time we executed that contract, we had 35 mental health worker vacancies. So we filled 24 of them up to this point, and that, you know, we're going to continue to try to find alternative ways to recruit for positions like nursing and so forth.
So not to nickel and dime you, but if FY22 showed a ramp up instead, if let's say it was 445 or 450 instead of 468 as a ramp up, that would take down some of your expense lines and maybe actually fit a recruiting reality better. Is that possible?
We could certainly think through that exercise. The one thing I would be hesitant about, so this is where we really have to dig into a staffing model on our side, is just that we can't partially staff a unit per se. So we either have to staff it or not staff it. You know, we'd have to really, I think, dig into that and do a pretty significant analysis to see what that right amount might be, if there's some sort of middle ground.
Well, I'd appreciate that, because it sounds to me that you're sitting at around 330 actual bodies now, 330 to 350. And so that's a lot of successful recruiting. But if you could really look at that, I'd appreciate it. Representative Wallner, you've had your hand up.
Yes, thank you. So on this page, could we take a look at the line 102, which is the contracts?
Absolutely. Would you like me to just? Oh,
yeah, could you just outline for us sort of what's in there?
Sure. So class 102 in this accounting unit, the primary expense is the Dartmouth contract. So it's a contract for all of our physicians and nurse practitioners at the hospital, all of the psychiatric providers. So that's a significant portion of that line. Another aspect of that line is our travel nurse contracts. So on occasion, we're able to secure travel nurses. It's been less frequent since the pandemic. The cost of travel nurses has skyrocketed due to the pandemic. And so we no longer really have competitive rates there. We tried to do a rate increase recently, and that hasn't really worked out well for us either. So, but the second portion of that is the travel nurse contract. I'm trying to recall if there's any other contracts in that line. Oh, and the temp to permanent staffing contract that I mentioned earlier as well. A portion of that contract is paid out of this line, and then a portion of it is paid out of the PASS Center class 102. So I think those three contracts comprise the total dollar values you're seeing there.
Okay, thank you.
Yep.
I was going to guess Hampstead hospital contract, but I would have been wrong. Where's the Hampstead hospital contract?
Hampstead is in 8400 class 102. So this line right here, you can see, because it's only been a partial year in fiscal year 20, we spent 330,000 last year. We didn't have anything per se budgeted because it was so new, but we have spent money there. And then really it's a structured contract. So we anticipate between 1.2 and 1.6 million a year moving forward.
So are you going to show up with an FY 2021 problem that we need to transfer money for?
No, not for the Hampstead contract. So the way that money was appropriated, we were given 5 million. That was non-lapsing money. And so, we have more than we need for this year. After 8750, we just have some smaller accounting units relative to specific functions we're either required to manage by law. I did also want to mention, obviously the hospital has a trust fund, so we have various accounting units for the trust fund. The trust fund is managed by a trust fund committee, and really does a lot for patient discharging. So the committee uses that fund for things like buying individuals shoes upon discharge, or paying first month's rent to try to get them out of the hospital. Those types of things. Really helping to enhance and facilitate discharging, and then occasionally doing random purchases on behalf of patients in some capacity to improve their experience.
Okay, my left eye had surgery, so I'm just having a little trouble focusing. Which line item are you referring to? Could you highlight it?
Sure. So let's see. So it's a bit challenging.
Oh, there, I see it. I see it
Yep.
now. Never mind.
So this line right here is the primary spend out of our trust fund. There are multiple accounting units that we use with trust fund money. So I think there's like 5 or 6, but this is the primary spend out of the trust fund right here.
That's a huge change. 738 projected for this fiscal year, down to 183. So what's going on there?
So that is a combination of the discharging spend that I had mentioned, and then the trust fund, after not getting furniture and renovations approved in a prior biennium, took it upon themselves to purchase and try to replace some things that were deemed a safety hazard for patients.
Okay, so we spent trust fund money on the furniture we needed for infectious control purposes.
Not all of it, just, and it wasn't so much for infection control. It was more to do with safety. It was things that could break and be used as a weapon or things of that nature.
Okay. In the Army, we used to refer to the color of money, that you couldn't use different pots of money for different things. And so I would just assume you're making sure that you all are spending appropriately from the correct pots.
That is correct. So the trust fund cannot be used to supplant operating dollars, and we coordinate with the charitable trust organization on doing that, or on managing our trust fund, I should say. It was really relative to patient safety issues and knowing that the funds had been requested in a prior biennium. That's where that purchase came from. So, but yes, we do actively work to make sure we're spending these monies in the most appropriate way.
Thank you.
And that's really it for the hospital.
Okay, are there any questions from the committee? I'm not seeing any. Okay, we're going to try something new. I see that we have about 25 attendees, and we'll see how many of you are listening, I guess. But if you have any comments or questions, go ahead and raise your hand, and Mr. Ripple and I will recognize you and bring you in. If you are a lobbyist, I ask that, since we can't see your badge, that you identify yourself as a lobbyist. Are there any hands raised? Mr. Norton, if you're out there, I kind of asked you a question earlier about pediatric care and having kids bordered in the hospitals, in the ERs. Or if you're there, I'd like to hear your thoughts. Yep, there's his hand.
Let's see. All right. Just move him over here.
Hi, Mr. Chairman and committee members. Thank you for the opportunity to speak. I thought that Heather and her team did an excellent presentation. Obviously, the situation with children is pretty dire right now. And as was represented, it's a little bit scary with the pandemic, not knowing where these numbers are going to go in the future. And that's a real cause for concern. Obviously, the decision to open the 10 additional beds at New Hampshire Hospital was a critical move, albeit it pushed the adult numbers up. And one of the things that I'm a little bit unclear about, and maybe Heather could answer this, is that when we contracted with Hampstead as a state, there were essentially two in-state options for children with psychiatric inpatient needs. One was New Hampshire Hospital and one was Hampstead. And so when we contracted with Hampstead, then there just became one option, Hampstead. And it's unclear to me whether we net resulted in an increase in beds or whether that combination of contracting with Hampstead resulted in a decrease of beds overall for kids. So that was one of the questions I had. And then, a couple other points that I wanted to make was that I just wanted to follow up the comments that Mr. Caristi made about insurance companies and commercial insurers paying. This is a significant issue in my mind, and something that we, NAMI New Hampshire, and others have been trying to address in a variety of ways. The New Hampshire Insurance Department does have a mental health and addiction advisory committee, but I think, as he alluded to, one of the concerns that I have is that the commercial insurance companies are, they have an obligation to their members to provide for capacity for inpatient and outpatient care. And it seems to me that part of what's going on here is an attempt on some level to push the care of people with serious mental illness onto the state. And that care should be borne across a number of different places, should be borne across insurance companies, should be hospitals. Certainly the state has some responsibility for that as well. But the fact that we're having so many folks in our emergency department waiting for boarding, in my mind, indicates that there's not adequate network capacity. And I applaud the fact that, that Anthem does contract with New Hampshire Hospital, but I question, even, if the numbers are low, why the other insurance companies don't. One other question I have is about the Imd exclusion. And sorry, I'm having a brain cramp about the acronym. It's the Institutional Mental Disorders Exclusion, which in the past has precluded use of Medicaid funds to pay for inpatient psychiatric hospital care at the federal level, but there is now a waiver process that's available for that, I believe, and I'm not sure how that plays into current or future budget issues. So those are just a few of the thoughts I have. Really appreciate all of the questions that the committee asked and the presentation that was given.
So let me follow up on your last item first, and that is who within DHHS owns the Medicaid waiver process that might pursue a Medicaid waiver for the New Hampshire Hospital for institutional care?
So I can actually speak to that that topic. We've actually been researching that waiver process for a little over a year now at this point. So the Imd Exclusion Rule that was that Ken referenced, essentially for patients between the ages of 22 and 64 who have Medicaid, their care essentially cannot be reimbursed in an institute for mental disease, which is kind of what New Hampshire Hospital is called from a regulatory perspective. And so for that portion of patients, a lot of that care goes uncompensated, and that gets into those dish payments I was talking about earlier. So the waiver process, there is a new waiver to try to get around that piece of law to some degree. And it's a portion of the Social Security Act that creates the Imd Exclusion Rule. So the waiver process would allow for payment. I believe it is up to, for lengths of stay up to 60 days. After 60 days, sorry.
So to quote a famous boxer, no moss, no moss.
Okay.
Just to keep us going, I wanted to make sure I knew that somebody owned the research problem, and it sounds like you're all over it and
Yep.
don't have an answer yet.
Can I just add very quickly to that, that this is also part of what the commissioner and I presented on in the department overview presentation, that we are hoping to have Alvarez and Marcel, which we refer to as A&M, a consulting firm, help us implement.
I thought Mr. Norton asked a good question. I had assumed if we were going to Hampstead, we would have been increasing our pediatric psychiatric beds on the net. Did we do that, or did we somehow reduce it accidentally?
We didn't reduce. It was a slight increase, and by slight I mean by just a couple of beds. At the time that we pursued that contract, we had seen historically that occupancy here at the hospital had been dropping from 2017 into 2018. When we looked at census trends at the time, again, pre-pandemic, making the transition to Hampstead provided enough beds based on the data that we had about referrals and patient days. So when we created the contract with Hampstead, at that point, we were only occupying 12 beds here for kids at the hospital and not at full occupancy. I mean, we were running with a census of 3, 4, 5 children on that unit. So when we created that contract with Hampstead, part of what we talked about was that they would occupy then a vacant unit. So upon doing that, that was sort of a wash. That vacant unit was, I think, 15 or 17 beds. And again, with closing that 12-bed unit that we had, it seemed like a number that would work based on trends with census. And again, that has all changed just during the pandemic. So at the time that we put the contract together, it seemed like there would be enough access to children at Hampstead. Not a huge increase in number of beds, but we didn't feel that they were needed based on trends.
And then you had a second question in there, but Mr. Norton, I wanted to come back, and it just seems to me that we do a lot of damage to kids who are hurting, need some mental health services, and then we're keeping them boarded in the ER. And I would like to know, relatively speaking, since we're not talking optimally speaking, but relatively speaking, would we be better off just getting these kids back home with some kind of wraparound services, albeit minor, than to hang on to them in a boarding operation?
Thank you for your question, Mr. Chairman. And that is a key question, and you're going to hear more about that this afternoon when the Children's Bureau of Behavioral Health presents. And to Heather's point, one of the challenges that we face as a state is how we determine capacity for inpatient beds versus community capacity. And community capacity, to your point, is the desired outcome. We want children to stay with their families, in their communities, in their schools with natural supports. There is a fast forward program which has been developed, which you'll hear more about this afternoon, which focuses on children that are at risk of placement outside the home and does provide that level of wraparound care. Again, don't want to exclusively pick on the insurance companies, but one of the issues is getting insurance companies to pay for in-home levels of support, particularly if they're not master's level or licensed clinicians. But to your point, yes, that is the goal, is to provide as much community-based in-home supports as possible. But that's also, I don't want to minimize the acuity of some of the children that are showing up in our emergency rooms right now in terms of their need for inpatient treatment.
All right, thank you. I'm not seeing any other participant hands up. Did you get all your questions answered, Mr. Norton?
Yes.
Thank you for stepping up. I see a hand raised by somebody, a panelist. There, Representative Irf.
Sorry, no, I thought you said there are no more panelists. I can wait.
No, you are a panelist. It's good to be a panelist.
Oh.
It's the attendees who are in the cheap seats.
Just a quick question. I must have missed it. What is the 6096, the community residence that's new apparently with 35 employees?
That's going to be our next presentation.
Oh, I thought that was part of the hospital. Okay.
It's part of the hospital's agency number, but we felt because it's a new facility and a new program, we would do a separate presentation on it.
Okay.
Okay, I think we're ready to go. Try to give us a 30 to 45 minute bite at the apple, and we'll break for lunch at that point. Hopefully you got a natural cutoff point for that.
Great. So are you seeing my screen right now for the Path Center?
Yes.
Great.
Yes.
Okay. So I actually think that this presentation will be a bit quicker than the others. It's shorter. It's a brand new program. Here's the agenda, the overview of what I'll talk about. It's very similar to the one that we presented for New Hampshire Hospital. And I think I might need technical assistance here from Joe. Oh, thank you. All right. Thanks. So contact information is listed here. We'll get into the overview. So the funds for the PATH program were appropriated as part of HB4 in the 2021 biennium. The department used a portion of those funds to establish the PATH Center, which is our 16-bed transitional housing facility located in the former Philbrook building here on campus. We opened in September of 2020. And right now the PATH Center, again, serves as an active discharge location for patients who are at New Hampshire Hospital, but are clinically stable and are awaiting housing in the community.
Where's that physically located? I'm imagining a building, or am I imagining it wrong?
It is physically located over at the former Children's Hospital, the Philbrook building, which in between housed professional licensure and the Board of Nursing. Do you know what building I'm talking about?
No, I imagine it's on the DHHS campus somewhere.
It is. It's on the it's on Clinton and Fruit, on sort of on the corner there, okay. The edge of campus.
Building in 1880.
I'm sorry, what?
I said it was probably a beautiful building in 1880.
I think it was around a little bit later than that. Joe, was it built in the 60s, maybe? 60s or 70s?
I think so.
Yeah. So this slide just represents where the PATH program sort of fits in with the inpatient mental health system. So you can see that it is a direct discharge location for us for some of our patients. You see here the mission and the vision of the PATH Center. And really this program is about allowing patients to be in the least restrictive environment that they can be, you know, according to what their clinical needs are. So folks that are referred to this program are, you know, psychiatrically and medically stable, and they literally are waiting for appropriate housing, but that is independent housing that they're waiting for. So in order to not, again, to you know, improve our discharge process and work on the backdoor issue. The idea was that the PATH Center could move folks out of New Hampshire Hospital, and then they work closely with housing specialists within this program.
So I have to ask it this way. Are you saying that these are folks that would otherwise be homeless and have nowhere to go? And so we're holding them until some kind of a housing arrangement can be found for them so they sleep under a roof at night? Or or are you talking about a specialty kind of housing?
So it is specialty in that there is additional programming. So I would think of it more of as a step down from New Hampshire Hospital. So most of these patients, so they have achieved clinical stability. They don't require hospital level of care anymore, but they are working on a bridge voucher. They are trying to find apartments. They are working on employment. They are needing to get connected with community mental health centers. So with the step down to the PATH program, they continue that work and then discharge to a setting that's going to allow them to continue to be stable.
Okay, but they're not necessarily homeless. They may have their own apartment or house somewhere, but we're still looking to give them a level of care.
Most of them have not found an apartment yet, but they're in the process with the bridge voucher and looking for affordable housing. But I would say, I will make an exception to that. We have had a couple of instances where we've had patients discharged to the PATH program who were going to be returning to their parents' home, but they had additional work that they were doing with counselors and also working on employment. So we have had that be part of their sort of transition to home.
Representative Wallner?
Thank you. They're all coming directly from New Hampshire Hospital.
Currently, yes, they are. Yep. We have talked about it being a potential placement location for other types of transitional housing that need a step down from their programs. But right now, we're keeping them full with referrals from New Hampshire Hospital.
So could I have a follow-up?
Sure.
So I remember in the past, people from New Hampshire Hospital, the staff there talking about people who had stayed in New Hampshire Hospital for many, many years. And have we been able to move some of those clients to the PATH program? I mean, it seemed like there were some people who'd been in there for several years because there was no place for them to go.
I would say that the patients that are being referred to PATH are not part of that population. So that population that you're talking about really has more special needs and an increased level of service. So it's not at the hospital level of care, but PATH is much more more independent than that. So many of those folks that were waiting for programs that are more like NFI, that are more intensive services, or maybe they are needing a group home. So that population PATH doesn't so much serve, but PATH definitely serves people who are homeless or pursuing housing, and that's extending their length of stay. So we are able to get patients discharged quicker with utilizing PATH beds for that very specific population.
Great, thank you.
You're welcome.
Representative Nordgren?
Yes, thank you, Heather. I thought there were also transitional housing availabilities in communities around the state. Are those included in your discussion, or are they overseen by the department, or what?
Yes, I believe that those residences that you're talking about are typically either run by a contract agency like NFI, or some of the community mental health centers run residential programs like that, and those are overseen by the Department of Behavioral Health. So they're not overseen directly by me. I only oversee PATH, but the department oversees the other programs.
Okay, thank you very much.
So for you to release a patient from the PATH center to say something like a group home, do those sort of charitable organizations, do they have to comply with the federal Housing First policies in order for them to qualify as a housing partner with you?
So patients that are being discharged from PATH are either going to their home with their guardian, or maybe their parents, or most often they're going into independent housing in an apartment with a bridge voucher. They're not typically going to another transitional housing location. Does that make sense?
Yep, and then do you keep any stats on if any of these are veterans?
Actually, I don't think we have yet, but that's a great point. Because, you know, again, those are additional for veterans. That's a whole nother path towards housing that could be pursued. So that's definitely something we could do. So again, just so you have an understanding of what, you know, the PATH program does and what it does not do. So it's transitional in nature. People are not living at PATH for long periods of time. They are supervised for their medication. There are continued therapeutic psychiatric services that are provided. There's really, the biggest thing they do is this intensive case management and discharge planning, which is working towards finding housing and employment, and then coordinating that transition to the care of the community mental health center. That's very important. One of the things that came up when we pulled PATH together was this question of, does that mean that everyone that discharges to PATH now is a Concord resident and now is part of Riverbend? And they are not. Our goal is for these patients to get to their home communities, wherever that may be in the state. So that's something that the housing specialists and the social workers work very closely with these patients on, to reconnect them with that community mental health center. We don't do it. Sorry, go ahead.
No, I thought you were taking a break there. What I was just going to ask, what the youngest age of an acceptable patient or client would be?
If they're over 18, it's certainly acceptable to be over at the PATH program. I would say we've had a range of ages of referrals, but really anyone over 18 can work with the team at PATH.
And you're obviously accepting all genders. You're not. Do you have? I'm thinking about the housing facility at the PATH Center, and whether or
Sure.
not there's appropriate segregation.
So they're all private rooms, but the wings there at the unit are co-ed. And then there are shower and toilet facilities that are, you know, assigned based on gender.
Have you had any incidences of harassment?
No.
Or the patients all getting along like brother and sister?
We've had a couple of incidents with patients that upon discharge maybe had some increase in psychiatric symptoms that needed to be managed by the team there. Again, it's a big change from this very restrictive environment here at New Hampshire Hospital to then to be at the PATH program. We've had a couple of patients that have been readmissions to New Hampshire Hospital based on that. So we haven't had any incidents of violence or anything like that, but we have had incidents where patients destabilized and needed to come back.
Right. I'm just worried about the security of the patients that are not as strong and able to protect themselves in case they have somebody come molest them. I mean, it's
Yes.
a co-ed. If it's a co-ed wing, you have co-ed issues, and so I'm just hoping you're on top of that.
I think it's a great point. Our campus police are also supporting the PATH Center. So we have close communication with them. They are at the ready if there's anything needed as from a security standpoint. The other thing is each of these patient rooms are private rooms and they are locked. The resident has the key to their room, and staff has a key to get into the room, but otherwise there is the ability to have absolute privacy. So when their door is shut, it's secure and it's locked. And we also have staff there 24/7. So there is an ongoing level of supervision all the time. So this is the team, the leadership team that's covering for PATH. So you can see Joe and I are on this slide. Ellen Lapointe is our Chief Operating Officer. And so she's very involved from the aspect of making sure that support services are in place as needed. And then our new director at PATH is Debbie Robinson, and she's a longstanding state employee, and she just started last month, but she's doing a great job. So you asked about about data, and we just really started collecting that. It's so new still that I think it's going to be really interesting to look at this year over year. But for now, this slide just shows you our gradual ramp up to get to, you know, occupancy here at the facility. So we did go a little bit low and slow over the first couple of months, but I think that was important. And that was also related to us filling positions. So to maintain safety, we sort of had to bring patients on board as we hired. I think it's too soon to say what the length of stay will be. That's what this slide represents, just based on our short period of time of collecting data. But like the slide notes, you know, any or all of these days could have been incurred at New Hampshire Hospital had we not discharged these patients to PATH. So in summary,
earlier,
sorry.
Yeah, no, earlier you guys had a national benchmark for the average cost of a psychiatric hospital per patient day. And I'm just curious if there's an equivalent benchmark for this facility, or if you've begun worrying about calculating your per patient per day costs.
Yeah, we have started doing that, and Joe can speak to that. I think where we were trying to show, you know, where the value was in this program was in comparing it to what it costs per day for a patient to be here at New Hampshire Hospital compared to at the PATH program. Joe, do you want to talk about the daily rate for PATH?
Sure. There is no real clear or solid benchmark that we've been able to identify. PATH serves a relatively niche population. But to Heather's point, in this presentation, in a few slides from now, we do have that that cost per bed day benchmark compared to the national benchmark, New Hampshire Hospital's cost, and then the cost per bed day at the PATH Center, to give you a sense of kind of the cost benefit trade-off of having that patient be at the hospital versus being at the PATH Center.
Great. Looking forward to it.
So this is a timeline of really the work that we did around opening this program. It was a pretty huge accomplishment, again, in the context of the past year here at New Hampshire Hospital and everything that we have sort of overcome and challenges. But you can see it really was over the course of the summer in 2020. Got the funding, built the accounting unit, created positions, started recruiting like crazy. The renovation of the facility was huge. You know, that we needed to work very, very quickly to get contractors in there and get that work done. And then ultimately in September, we got our approval from the fire marshal to occupy, and we opened, and as you could see in the previous slide, filled. The slide just represents our challenges, short-term and long-term. Ultimately, what we would like PATH to be is a structure to be replicated throughout the state. So we thought, you know, if this is, if we can build this model, you know, can we duplicate this over and over again, hopefully with partners like community mental health centers that can get more of these locations throughout the state, understanding that there is going to be some variability in the level of service that's provided. At the PATH program, it is definitely a step down from New Hampshire Hospital. We do provide service, but there are a number of patients that we have here that are not appropriate for PATH because they need a little bit more, or they need a longer stay in a housing situation that has support.
Representative Wallner had a question.
Thank you. Actually, my question was, were you going to try to replicate this in some other areas? Have you identified any areas yet, any areas of the state that you might try to replicate this program?
We haven't identified a specific area yet, but our feeling is that certainly in the lakes and in the North Country, that it seems like there could be good utilization in those areas. But, you know, census-wise, we do have a large, population that is in the Manchester area and Nashua. There are other transitional housing options that are already there, though. So I think it really will come down to who can we partner with, for in particular from potentially a CMHC, and work closely within an area where it's needed. But I think our general feeling was perhaps Lakes Region or the North Country. It's just soon to say.
Great, thank you.
You're welcome. So I think this slide speaks to your question, Chairman Edwards, just around, how can we figure out value here of what we're doing? So Joe spoke to this. There really aren't any benchmarks, but what we can do is try to do some calculations based on that value of the patient, not being here at the hospital level of care. So I think this slide does a good job in showing that.
So a green eye shade question. Does that 729 include the amortization of all the renovations and one-time licensing costs? Or is that just direct operating costs?
I believe those are operating costs, correct, Joe? Yeah.
That is correct. That is correct.
Okay, so if we wanted a fully loaded number, we'd take a look at the amortization of the renovations. Would that have a material difference on that number?
I don't think it would. If I'm remembering correctly, I believe our renovation budget was 170,000. So it wasn't so much a massive renovation or overhaul of the space. It was more about the timeline we had to do it in. So it was, getting numerous contractors in the space at the exact same time and really trying to stand this program up quickly.
I didn't see whose hand went up first, but Representative Nordgren, you're on top.
Thank you very much, Chair. So this page would be nice if we also could see what the cost comparison would be if these people were kept in the state hospital. So this is obviously like a step-down unit and it's costing less, which is freeing up beds in the state hospital. It'd be good if we could just see what the comparison would be for all these numbers across the board. Thanks.
Yeah, I think that it also will be helpful to have another year, of operating that we can really sort of drill down to and see if there are opportunities to reduce the cost even more. This is such a young program. And in standing things up, I think it costs a little more in those initial, 4, 5, 6 months. So I think we'll be able to be much more accurate in this next year. But, as it stands now, we're looking at, really cutting in half what it costs to take care of these folks, compared to if they were in New Hampshire hospital, roughly.
It's a brilliant initiative. Thank you. So Representative Wallner, do you have a question? You're muted.
No, I just needed to lower my hand. I'm sorry.
Oh, okay. All right. Anytime.
So this is the slide again that we're asked to, show what would happen with an increase or a decrease.
Let me devil's advocate you on this first one.
Sure.
So this path model is brilliant. It's helping us cut costs. So if we were to replicate it, why wouldn't the money already be there in the New Hampshire hospital budget because this is a cheaper model? Why would this be incremental dollars?
I guess I don't understand the question.
I can cover it. It
Sure.
would still be an increase to the total budget because we still need the total number of beds at New Hampshire Hospital. So
we're not decreasing beds at the hospital as much as we're decreasing
Correct.
the burden around the inflow and outflow of the hospital. All right. I understand.
And as far as the decrease where, there's this 5%, just to explain that a little bit more, where we wrote that we would decrease capacity, I think it's important because it's so small of a unit and the staffing is so small and already so lean that it is just right sized as it is. So, a decrease in staffing would represent us, definitely not being able to take care of as many people over there. So
Without making any promises, the way I look at this Path Centers is it's a great innovation experiment that should be allowed to proceed, because if you're showing us a way forward where we can deal with these other problems at a significantly lower cost, then that's brilliant. That's what we need. So
thank you.
I wouldn't want to come after this.
Thank you very much. We're excited about this project. It's been just a great challenge, and to see it pay off as it has, you know, with discharges is it's pretty powerful, I think. So this speaks to, again, just the number of positions. This center employs 35 staff across 3 shifts, 7 days a week. Essentially, they're all direct care.
How many of those are actual RNs? And are RNs the most senior level of nursing care that you have on site?
Yeah, we have 2 full-time RNs and I think a part-time RN. Those are really the only nursing staff that we have. Then we have a complement of mental health workers that are there, direct care, and again, helping doing, you know, therapeutic groups and really safety and supervision. What the staffing,
Master's level?
not the mental health workers, no, but the remainder, at least half of the staff that are over there are master's level social workers and case managers and housing specialists. It's a very heavy social work driven program.
So someday, not now, that it'd be interesting just to see sort of the diversified staff that you've done. It's kind of the multidisciplinary approach that you've used to build that.
Mm-hmm. Sure.
Not urgent, just in months coming.
Yeah, so really the staffing model, essentially. Yep, we can do that. So Joe, do you want to talk about this budget comparison?
Sure. So in the current biennium, as we mentioned earlier, this was really created through an appropriation from House Bill 4. So we used $2.7 million to create the program in the current biennium. In the future biennium, we do anticipate earning some revenue. So quite frankly, we anticipate earning some revenue in the current biennium as well. We've just we're working through some systems issues with that, but we can bill for a per diem rate for transitional housing. We will receive an in-kind payment for that. So essentially the federal share, we won't make Medicaid pay us state dollars because we're all state funded. So we do anticipate being able to earn some revenue there. And then we will be charging residents some rent. And we're working on developing that program. And we didn't do it out of the gate initially, but we're pretty close to implementing that practice. And the intent is to have it be cheaper, obviously, than the cost of care at the hospital, but also kind of reflect that we are providing a housing service. And so we anticipate charging some rent to patients as well.
I think there's also the psychological that people value things that they have to pay for themselves. So they get more buy-in, I would imagine, if they actually have to buy in.
Sure, yeah.
Absolutely. I mean, that's, I think, a critical point for us in that this is a step down. Patients, they have the opportunity, and they should, you know, as able, pay rent, but also incentivizing them to find their own housing too, right? I mean, this is not long-term free housing. This is something that is a process that the patient's going to work through.
And I just want to also add to that $7.1 million general fund amount. That's incorrect. I need to revisit that, but the total cost of the program is just shy of in the 2022-23 biennium is just shy of $4 million. I think it's 3.8 million. So I will revise that and get an updated copy for you.
Thank you.
And again, this is the accounting unit that's listed.
Okay. Are we ready for the briefing book, the budget briefing book?
And that's the conclusion of the presentation on the PATH program on my end. I don't know if you need to open something, Joe. I can stop sharing.
Let's So let's see. So here is the budget book. It's page 1144. It is the first accounting unit within Agency 94. And I'm happy
What's
to
that
take
activity number? Do you know?
it.
Can you tell me?
6096.
Okay, got it.
The activity number is 9400,
Oh, I'm sorry. Yep,
accounting unit.
correct.
So I see it listed as community residence.
Yep.
Okay.
When we created the accounting unit, we didn't know we were going to name the facility yet. So
I'm not, oh, okay, there I am seeing. I see 35 FTEs. Yeah. All right, good. Go ahead.
So pretty similar to other slides. You know, the majority of this cost is relative to staffing and payroll. In the 2021 biennium, we did have some one-time costs that we have excluded from our budget request moving forward. So those were things like, you know, our initial purchase of furniture, the renovations to the building. So we did reduce those budget lines. You can see as an example, class 48. You know, we had $193,000 budgeted for that, and moving forward, it's going to be, you know, closer to 26,000. So we've pulled out those one-time costs, and really the rest of the majority of the cost here is relative to staffing. And yeah, I'm happy to take any questions.
Okay. Are there any questions from the committee? Representative Weiler?
Thank you, Mr. Chair. I'm looking at heat, electricity, and water. And I'm thinking this is, you know, something like the size of a home, maybe twice the size of a home. And those heat, electricity, and water, 100 and some thousand, seems awfully high for just providing those two.
So I apologize, I didn't mean to cut you off.
Go ahead.
So that value represents the cost of utilities for the entire building. So it is a 16-bed program, but the entire building is kind of operated by New Hampshire Hospital now, or our kind of collective entity. So and that number, I believe, was provided to us from DAS.
So I don't want to beat you up on your average, that $750 average, but if you take that annual cost of water and electricity and divide it into that, that seems to me like that would challenge your 750 number right away. You know what I'm saying? It's just a lot of money. And I don't know how you get a $750 per patient. Is that per patient per day? Or per patient? What is
Per patient per day.
So, all right. So I'm off in my head by an order of magnitude. It's okay. Sorry.
Sure.
Any other? Oh, I'm sorry, Representative Wallner. You had your hand up?
Yes, and this is just kind of a simple one. I'm sure you have there's an explanation for it. So I'm looking in 2021 and under line 60 benefits, you have $500,000, but yet I don't think we had any personnel. I don't. So how would we pay? What were we paying benefits on?
Sure. So great question. And there's actually 2 points I'd like to make there. So to answer your question directly, these positions, because they were created outside of the budgeting process, are considered 8T positions. And so they show up in that class 50 line there. So you can see that there's $1 million worth of payroll in class 50. Those are technically full-time positions, but they're temporary until they're approved in a budgeting cycle. So So there's that. And then I also want to just mention the difference between class 60 for 21 and 22 is that 21 is not an entire year. So, so that budget does not represent a full year's worth of cost per se.
Thank you.
Yep.
Representative Nordgren.
Thank you very much, Mr. Chair. So you, you said $750 is the per day cost per client. What is the per day cost at the state hospital?
It is, I believe in the upcoming biennium, what were the numbers? 14.
Roughly 1,500, I thought.
Yeah, $1,500. Yep.
Okay, thank you very much.
Sure.
And your hand is still up, Representative Nordgren. And now Representative Weiler, your hand is back up, sir.
Yes, I'm looking at benefits, paying $1.5 million pay for the 35 people and then $1 million for benefits. So it's like, 60% of the cost of an employee, again, in benefits seems awfully high, but I know we're very generous in our benefits, but that's still a little bit much.
Those numbers are set by the Department of Administrative Services. We have no control over the benefits number.
So sir, I think we've seen that in other departments at 60% ratio.
I think that's just one, we've got to talk to DAS because that's one of the big figures that goes across the whole state. We've got to try to find out why those benefits are so high. I know some of it's the retirement system has done a lousy job of investing, and so has the self-insured done a lousy job of getting the third party administrator. Those are things we've got to look at as a big picture for the whole budget. Thank you.
All right. So are there any other questions from the committee on this in this area, the Path Center? So I'm not seeing any. Let's give the public an opportunity. If somebody on the attendee list wants to raise their hand to add some useful knowledge for us or to make a salient point, we'd be open to hearing it. So there's one by Mr. Norton. You want to bring him in, Mr. Ripple?
Sure. And he
Thank
should.
you. Mr. Chairman, it was just that last time I neglected to introduce myself appropriately. I'm Ken Norton. I'm the Executive Director for NAMI New Hampshire, the National Alliance on Mental Illness, and I am registered as a lobbyist on behalf of NAMI New Hampshire.
Thank you for correcting that. I think it's just important that we know you're obviously a well-respected individual, but it's good to know that you're a lobbyist. Thank you.
Yeah.
Do you have anything else to add on this part?
I mean, I really commend the commissioner and Heather and her team. I think that there was a lot of forethought. We would be in serious trouble with emergency department boarding for adults without the PATH program. It's definitely helped alleviate that in a big way.
What do you think about the potential for replication? Are we going to run into the same manpower problems when we try to get out to the Lakes region?
It continues to be an issue for sure. But again, I think that having some ability to look at credentialing standards and, well-trained and well-supervised staff that aren't necessarily licensed folks can be a big help. And peer support as well.
So, Ms. McQuinn, I think you're going to say something. McCowan, I'm so sorry. I'm horrible with names. I got Heather, but I'm trying to be more formal.
I used to be a Smith and it was a lot easier back then, but it's Heather Moquin. And
Okay.
no, I was just going to echo what Ken was saying. I think we have to get really creative throughout the state around these workforce issues. That really needs some serious attention.
So I just want to throw a crazy idea out at you, and that would be internal virtualization of the operation, meaning the exploitation of commercial off-the-shelf technologies to provide cameras and audio, and so that maybe some of the supervision of the wings could be done remotely without having on-site and present people. Just a crazy idea from an old telemedicine guy. All right, so not seeing any more questions or comments from the attendees. I think we should probably take a lunch break here. We got 2 more areas. I'd still like to finish at 3. Last time we broke for 45 minutes. Or is there anyone thinking that was too much time? Oh, wait a second, Representative Wallner, go ahead.
No, I'm sorry. So in House Bill 2, which are we going to get the final copy of House Bill 2 this week?
Let Mr. Ripple answer.
I think our expectation is that we're going to get it today, but obviously I'm not positive about that.
Okay, well, I'm looking at the draft, and so I would just like to know if we're going to have someone come forward to do some explanation for us, because this is around the 60-bed for forensic psychiatric hospital that is to be built on New Hampshire hospital grounds. And it isn't only in House Bill 2. I don't think I have found it in the budget, actually. So I just wondered if we were going to have someone come forward to give us some explanation about that and where we are in the planning of that.
Karen, I don't know if you have anything to add to that. I was just going to say that there has been a work group. So even last year, there was some study around just potential sites here on the campus. So there was some work that was done with that. And there's been some ongoing discussions on the part of DAS, and Commissioner Arlinghouse has been doing some research. And that's as far as my knowledge goes at this point. I don't know, Karen, if you have anything else.
I can just add, as far as the appropriation in the fiscal year 2021 budget was non-lapsing. So that's the appropriation that's intended to be used as this project moves forward. And I know that there is an intent on the governor's part, as you can see from the HB2 language, for it to move forward. And on the department's part.
Okay, thank you.
You're welcome.
Okay. I think we were getting ready to go to lunch. So I'm proposing about 45 minutes. Was that too long or too short? Were any committee members want to offer a counter proposal?
30 minutes, I'd say. I got to be out of here by 3.
Okay, so let's say that we'll be back at 1:15. And until then,
Thank
we'll
you.
recess for lunch. 1:15. Mr. Ripple, I see your email about maybe using Wednesday if we need to. I'm kind of optimistic we can finish today.
Okay,
It just saves the presenters the scheduling problem of having to come back.
sure. Nope, that's fine. I do think they may be ready to come back if needed, but if we can get it done today, even better.
Okay. So Representative Irf may Zoom as he's literally zooming in his car to a destination. Representative Weiler, Representative Woolner are not back just yet.
Representative Wallner's here, but her video won't start because it says you cannot start because the host has disabled you, which might be a good thing.
Hold on a second, let me try to fix that.
So you know, I didn't tell him to do that.
Oh, sure you didn't.
No, I turned everybody's video off at lunch.
Probably a good idea. Okay, so Representative Weiler is here. Sir, would you remind me what your drop dead time is? When would you like us to be done?
I have a gopher meeting at 3.
Okay, and you probably would need a few minutes just to transition. So
I have the same, this is Mary Jane, I have the same meeting, so if maybe, what, Ken, do you think maybe like 10 of 3?
Yeah, it'll probably take me a while to find the link.
Me too, that's what I was just thinking. Okay.
all right. Okay, well, very good. That's our time schedule. Let's see if it can happen. But Mr. Ripple did allow for us to continue on Wednesday if we need to. So, but let's try not to. I'm ready.
So Chairman, this is Heather. I wanted to introduce Todd Bickford. He's the nursing home administrator at Glencliff Home. I'll be moving through the slides, but Todd will be the person presenting. Okay.
Very good. I'm going to turn my video off so I can chew.
Heather, do you want me to start right from the beginning or do you want to do the first 3 or 4 slides?
Nope, you can start from the beginning. That's fine.
Okay. Is now a good time to start, Mr. Chairman?
Sure.
Thank you everyone for allowing me to present in front of you today, this afternoon. And I have to say it's been very interesting watching the first couple presentations. Very similar setup with our PowerPoint slides here. This is our agenda, which is basically the same as the last couple. On your next slide, you'll see again our contact information. You know, Heather is the CEO of New Hampshire Hospital, but she's also my direct report. And then Joe is the CFO for both Glencliff Home and New Hampshire Hospital. And trying to stick with the moving fast forward, we have our overview and delivery system. Some brief history for those of you that are not familiar with Glencliff Home. We started in 1909. Actually, 1906 is when the legislation was first passed, but we had our first patients in 1909 as a TB sanitarium. Because back then, treatment for TB was fresh mountain air and sunshine, and we are located on the side of Mount Moosilauke, up here in the North Country. Then in the 70s, when there was now treatment for TB, the legislature at the time decided to transition us into a nursing home that specializes in serving individuals with psychiatric or developmental disability issues. And actually at that time, it was close to when the state school in Laconia was closing, and we've got a fair number of patients from there. In addition, there was a building on the main campus of DHHS in Concord, their building, which had over 300 beds. very similar model as Glencliff is, and at that time it was decided to downsize that facility and relocate a number of people here to Glencliff. We serve part of the back door, as the term we've been using today, solution for New Hampshire Hospital. We do have a long wait list, which I'll get to on the future slides, but we take priority from New Hampshire Hospital. It's actually, we had it added to law that New Hampshire Hospital gets priority for any beds that are available. All right, on the next slide, you'll see where we fit in. Again, it's demonstrating that we are part of the discharge process for New Hampshire Hospital. Pretty straightforward. And then our ultimate goal is to move people back into the community as well, which speaks to our mission. Continuum of service for developmental and mentally ill population in a home-like atmosphere and emphasis on independence, dignity, and acceptance. And I do like to speak here that the real key word for our population is acceptance. Our folks have had challenges their whole lives, and now they have medical challenges on top of their mental illness or developmental disability, and have been in and out of New Hampshire Hospital in some successful placements in the communities. Often a lot of people come to us where they've been living in a group home or living in their own apartment, dealing very well with their schizophrenia, but now they have COPD or they have brittle diabetes and they have other medical needs, which is just compounded by their mental illness. So they need additional support. Our long-term vision is basically the residents will live a full life and gain independence by overcoming their challenges and developing the skills to move back into their preferred community. And on the next slide, unless there's questions, sorry if I'm going too fast.
I do have a question there on your previous slide. And you've kind of said it twice about the vision. Okay, so in practical effect, is this really an aspirational vision, given that my sense of this population is they're kind of, for lack of a better word, set in their ways. They're elderly, they have psychiatric problems. They're probably really not gonna go back home and just live a normal life. Or am I wrong?
You're not fully wrong. In a future slide, you'll see we've been able to discharge 26 people in the last 3 years back to the community or to a group home or to another nursing home. But right now, I believe we have 26 people actively working on being discharged back to the community. Now that might take a year, that might take 2 years, either for them to develop the skill sets that they need to be independent or for us to find placement, because we have the same challenges, if not more challenging than New Hampshire Hospital does with finding housing, because all of our folks need some additional medical help. Where we have been successful in discharging people is to either group home settings that have been set up with a medical model, or into home situations like elder care. So a family agrees to take one of our residents into their home and provide services through that way. It's very specialized to the individual. So that's about 20% of our residents are actively working on going back into the community. However, a large portion, as you say, we are a nursing home. So, people are coming to us with some severe medical challenges on top of their mental illness. So that does make it challenging for them to move out. And quite honestly, vast majority of our folks don't want to go back to the community. They have tried and failed before, and they found a real home and community here. So we are required by CMS to ask the residents every 3 months if they're interested in moving back in the community. And typically it's about 20 to 30% say yes, but the rest are more than happy to be here. And their families and guardians are also very happy to have them here in a safe, structured situation.
So that would imply, and I'm not trying to be morbid, but I just want to understand your setting. That would apply that a very large percentage would be discharged into hospice care or just death.
You are correct. We do hospice care here. So think of us as a nursing home. We're very similar situation as the county homes, except for who we serve. And yes, we refer to as celestial discharge when someone passes away.
Say that term again.
Celestial discharge when someone passes away. It's a nice way of saying they died.
I've never heard that term.
We made it up here at Glencliff. We're unique up here in the North Country. Moving on, so again, a little more history. We are located up north. We're 69 miles northwest of Concord, on the side of Mount Moosilauke, and technically we're in the town of Benton, but you can't get there from here. That's why we're called Glencliff Home, because the closest village is Glencliff, which is part of the town of Warren. We provide a full continuum of services like any other nursing home, including medical, social services, pretty much anything that an individual needs. Part of what makes Glencliff unique is that we are self-sustaining campus. We are off the grid. That's how we were originally built. We have a water wheel that produces about 35% of our electrical power. And we actually have a capital project to double that. And when the water wheel, just for an example of how useful that is, when the water wheel is functioning, we save 100 gallons of diesel from the generators every day, which is a significant savings. We're also working on adding steam turbines because our campus is heated using steam heat. And we, about 8 or maybe 10 years ago, we transitioned to biomass generation. So we burn wood chips to create all of our heat and hot water and hopefully electricity in the future. And I always love to invite anybody to come up for a tour post-pandemic. Clients and services. Again, I spoke briefly about this. We provide a full continuum of any nursing home. Main focus is on nursing care, adult living care. We do provide recreational services. Pre-COVID, that would include trips to the community, shopping. We rent a house on a lake once a year so residents can go swimming and do some barbecues. We provide all the environmental services such as housekeeping, laundry, maintenance. Dietary, we're actually very well known for our food. Most nursing homes have a difficulty with residents losing weight when they're admitted. We have a difficulty with residents gaining weight. So that is something that we're constantly working on with our dietitian. So we do also strive to use as many non-medication modalities and alternative approaches as possible. We have staff trained in things such as Reiki, just peer-to-peer support. We do things like that. Just try and redirect somebody. And again, that takes me back to part of our mission where we accept people for who they are. In other nursing homes, they really have a difficulty dealing with somebody that has a behavior where they're verbally disruptive, they're screaming or yelling out. Other nursing homes have to market themselves and sell themselves, and it's difficult when they're giving a tour and someone's acting out. We, having the benefit of being run by the state, do not have to market ourselves. We actually always have a wait list, as you'll see in a future slide. So we end up taking the people that no one else will. We actually, knowing that we're a scarce resource, have required for the past 15 years that for when someone applies to come here, they have to demonstrate in writing that at least 2 other nursing home facilities has rejected them and turned them down. And usually it's many more than that. Again, we strive to take people directly from the Hampshire Hospital. In your conversations with the Hampshire Hospital, you asked about redirecting people from the ED instead of going to the Hampshire Hospital. We occasionally are able to do that with an elder, at least a couple of times a year. It's not as frequent as we'd like, but sometimes we can do a direct admit from one of those situations to help relieve that situation. All right, on the next slide is a picture of our staff. I think it speaks to the dedication of my staff, as similar to what Heather was talking about in the Hampshire Hospital. I've been here 20 years, hoping to be here for another 10 before I can retire with the state. A large number of my employees have been here for quite a long time, including the direct care staff. This last year or 2 has been challenging. A greater percentage of our folks now fall in the 1 to 5 years, but about 60% of our staff are still in the 5 years plus range. All right, the next slide is a nice aerial shot of the facility. So we maintain about 70 acres now. Back in the history, we had over 500 acres and we did our own farming, had cattle and pigs and those kind of things back in the TB days, but now we just maintain a much smaller campus, but that includes, again, the power plant, a laundry facility, some outhousings that used to be like the head herdsman's house, but we now use to house traveling nurses, maintenance shops, and then the main large building that you can see there is the resident areas. And then the other buildings are used for administration and training and things like that. Thank you. Moving on to our key performers. So our census, the difference here that you'll notice between what we budget for and our actual billing monthly census is really largely due in the past to billable days. So as a normal nursing home, we bill at midnight. So if we have a resident that for some reason needs to go to Cottage Hospital or our local hospital for 3 days, we can't bill for those 3 days. So even though they're technically in a bed and we cannot fill that bed, we're required by CMS to hold the bed for a certain length of time, we can't bill for it. So that drops our averages. Ideally, we get up to 118 filled beds so that our averages will fall back closer to 116. But I can tell you this last year has been very challenging, not only to the obvious COVID-19 challenges that every nursing home has faced in the state, but also with staffing issues. Any questions so far?
Well, I was just going to ask, looking at that aerial photo, is there room to grow? Do you have any on the shelf plans to build more?
Actually, that is a great question, and I am thrilled that you asked me. So if you're looking at the picture, inside the horseshoe of the large building, we actually got, not this biennium, but last biennium, we got a capital project to fund the design and blueprints to be of a specific dementia unit. Right now we have 4 units. We would be building in that ground. We would actually sink it down into the ground and it would have a live roof. So all of those windows would look out over this new building. And we would add 26 beds specifically designed for dementia patients. Because as I'll talk about shortly, one of our challenges is that over the last particularly 10 years, more and more of our folks have developed dementia here, and more people on our wait list have dementia. So now you're talking about somebody that has a nursing home level medical issue, someone that has a mental illness or a developmental disability, and on top of that, they're now developing dementia, which is particularly challenging for us because the techniques and strategies that you use with somebody that's suffering from a mental illness and having those kind of behaviors don't always work with somebody with that has developed dementia. And what we're seeing happen is someone who has developed skills to ignore the voices in their heads per se, now they've got dementia and they've lost those skills. So their mental illness gets exacerbated by the dementia on top of the challenge of a dementia that anybody would have. Probably more than you asked for.
Do you have an exterior fence to keep dementia patients from wandering off?
Yes, you can't see it in this picture, but right on that tree line, so that's a fire break that goes around the whole campus. Just inside the tree line, there is a fence all the way down to that road for the very specific person that if we did have somebody that was a flight risk or a wander risk get out unsupervised, it would funnel them down towards the maintenance shops and the main road so that more staff would have a chance to find them. Knock on wood, and not trying to curse myself, but my 20 years, we've only had 1 incidence where a resident was missing, and we put in our plan, which involves the state police and dogs. But even before the dogs got here, staff found him. He had climbed over the fence. He was more physically able, and he climbed over the fence, but we found him. Thank God. So that's the only instance of that. All right, so I think we were on slide 14. This is our wait list. Typically, we've been between 20 and 30, but you'll see a huge increase starting when pandemic started. We found an increase on people that couldn't get into other facilities because of the challenges. We had difficulty discharging people to the community because of other challenges, and our staffing has really been suffering this last year. So there has been periods of time where we have froze our census because we just don't have the staff to take care of a full complement of residents. So right now we have 44 people. 14 of them are at New Hampshire Hospital. Key accomplishments, and I'm extremely proud of my staff for this first one. We have remained COVID-free throughout the whole pandemic. We have been extremely fortunate. I think this is one of those cases where being in a remote location has helped us. Where it hurts us with recruitment, it certainly helps with the pandemic. Well, my staff deserves a huge credit. They've done an excellent job of doing all of the things that CMS requires above and beyond, and screening, taking care of things like that. And at this point, we have 93% of our residents have been fully vaccinated, and the 7% is because they chose not to. That was an individual's choice to be vaccinated or not. So we're very proud of that one. Second accomplishment, we implemented back in 2017, really, doing an LNA class because we are really hurting for staffing. So we've realized that we need to grow our own. So we have, in the last year and a half or so, graduated 28 LNAs and 3 MNAs. An MNA is a medication nursing assistant. So it's an LNA that has an additional certification so they can pass medications. They can't assess or diagnose, but they can pass medications. And then if they see a resident that might be having an issue, they can go and get a nurse. So that has helped with our staffing somewhat. And then, as I mentioned earlier, since 2017, we have discharged 26 residents back out into the community. And again, this helps us admit patients from New Hampshire Hospital and other facilities. Really, part of the backdoor solution. Key accomplishments, we are an old campus, a lot of old buildings. You referenced earlier today, a building that must have looked great in 1880s. Well, some of our buildings looked great in 1806, 1809, and now they need a lot of work. We have gotten some capital projects in the last few bienniums, the last one being improving our potable water system. Historically, the facility has used basically a dug well up on the side of the mountain, established in 1940. It's a 30-foot round, 30-foot deep dug well. It provided all the water up until the last couple of years where we have had to add some additional artesian wells. And we're looking actually to remove the dug well offline with a couple more wells as recommended by DES. And then things like improving the fire access road and a roof and boilers and generators and all those kind of fun things. Key challenges. Front door for us, obviously, a wait list of 44 is not acceptable. That means a large number of people are waiting to get into the facility. For us, they are mostly not in EDs. Occasionally they are. Most of them are either still at home, at a hospital but admitted, but they're looking to place them, or at New Hampshire Hospital. And that is our biggest customer is New Hampshire Hospital. And then, as I mentioned before, the significant increase in referrals with patients with dementia. So dementia itself is not a diagnosis that will allow somebody to come here, but like I said, they often are paired with somebody that has medical issues on top of a mental illness and now have dementia on top of that. Our backdoor issue is, as you've heard a couple of times today, housing in the community and support systems in the community, because our folks not only have to have the supports around their mental illness, they also need to have the supports around their medical needs. Diabetes being a great example. Someone might mentally and cognitively be very capable of living in a group home, but most group homes do not have a nurse available to do injections and to do insulin, and these individuals are not able to do them themselves. Very much related to that is the support staff in the community. Operational, our real big one is recruitment and retention. The hospital spoke about a number of initiatives that they've taken. We've taken some similar ones, but we are really struggling, particularly because of our location. Those 28 people that we've put through our LNA program, we just offered a program to start in February, and we had nobody apply. We've kind of tapped all of the resources around us, so we're starting to expand that circle. We're advertising further out, and basically, it's grow your own. So if someone agrees to take the class and be an LNA with us for a year, it's free for them. So initially we had a number of employees that came from other departments such as dietary and housekeeping and laundry that took the class and became LNAs. And then we had a number of people from the community. Unfortunately, not all of them have stayed with us after their initial commitment. And then we have the typical challenges of operationing a 100-plus-year-old campus, furniture, equipment, buildings, those type of things. Moving on to benchmarks when it comes to staffing. If we were to get a 5% increase, I'm sorry, your question.
Bickford, yeah, would you give me a call after this? I have an idea too crazy to say in public.
Okay,
I want to share an idea with you.
okay, I will certainly do, like today.
That'd be great.
Okay, I will do that. So if we were to get an increase, we would put that towards additional professional recruitment of staff. We have been using some travel nurses. We have talked with New Hampshire Hospital about increasing some of those contracts and how much we pay for nurses, but also number of contracts. The COVID has really hurt us there. Pre-COVID, we were using 3 to 5 travel nurses at a time. We have 2 right now, and we're lucky to have them. Because a lot of places like Florida were offering huge sign-on bonuses and things like that for travel nurses that we were just obviously not able to compete with. Then we would put more money into improving resident living areas and then facility maintenance and equipment upgrade. If we were to get additional cuts, obviously we would have to take that out of staffing. About 83% of our budget is personnel. Joe can correct me if I'm wrong on that number. So unfortunately, we would have to eliminate vacancies first for savings, but a lot of that vacancy money we are now using to pay the agency nurses and to pay for overtime. So we're maintaining safe staffing levels, but that is heavy use of overtime and travel nurses. And then we would, do the typical defer equipment and maintenance projects. Questions? So this next slide speaks to our staffing challenges. Obviously the first line is our nurses. DRS is just another term for Director of Nursing. So we have 31 nurses in total. That includes 5 nursing managers. But please don't think of them as administration. They work the floors. Even our Director of Nursing, we're at the point where she's working 8, 12 hours, 16 hours out of her 40 hours a week, direct care, giving medications and providing care to the residents because we are so low staffed. That number is actually a little deceiving, 38% vacancy rate for nurses. It's a little higher because we have an individual out on FMLA. But when you break it out by shift, our second shift nursing is at 62% vacancy rate. So that requires us to have nurses from day shift or third shift move on, do overtime, cover shifts. We are, in the last year and a half, first time ever mandating nurses. We never had to in my 20 plus years till this last year and a half or so. So we are really struggling with nurses. Same can be said with LNAs. Not quite as severe. The overall vacancy rate is about 22, 23%. But if you look at third shift LNAs, we're at like 40% vacancy, and second shift is about 35%. We obviously do better on day shifts because people like to work during the day instead of nights and on weekends. So other than that, we do usually pretty well with recruiting. We have some vacancies in some of the other departments, which is a new thing for us, and I think it is somewhat COVID-related. We never even used to have to advertise for positions other than nurses and LNAs. And this year we're finding that we do have to advertise and put some more effort into finding people that are looking for state jobs. Questions?
So do you have an on-call sleeping facility there so that if somebody is working overtime, they could go crash for a few hours?
So we do have, there's a couple of houses on campus that I mentioned earlier. We use one for travel nurses. So the other one is available for nurses. Like a couple of weeks ago when we had one of those bad storms, we had a nurse that was working second shift. He asked if he could sleep over because then he was going to work first shift and second shift. He's going to do a double the next day. So we do things like that routinely. And then we also use them for the travel nurses. So there is some of that. And then due to our nursing shortages, the director of nursing and the nurse coordinators have all taken on on-call duties for the weekends, so that if a nurse calls out sick, one of those nurses gets called in. But we're really burning out our staff, so that's why, excuse me, that's why we have frozen admissions and off and on.
Representative Wallner has a question.
Thank you. Did the staff at the at Glencliff also get the 20% pay enhancement that was provided for New Hampshire Hospital?
Oh, no, they did not. New Hampshire Hospital went forward, they were also at a critical staffing for 20% for mental health workers. My staff are LNAs, so they were not included in that. That is something we are looking at potentially asking Governor and Council for, but we haven't at this point, so it's not included in this budget.
Follow up?
No, thank you.
Representative Weiler?
Thank you, Mr. Chair. I see all those buildings on that campus. Does any of the staff live on campus?
Just the travel nurses.
They're the only ones. It seems like what kind of commute do most of them have? You're fairly remote. How's the longest road you've got to get to your facility?
Well, my deputy administrator lives in Concord, so she travels an hour and 15, good weather. I'd say the average employee is probably 30 minutes. We have some that live right here in Warren, so they're 15, 20 minutes. But then we have people that come all the way down from Littleton, Lisbon. We have a number of staff that live in Vermont. So I'd say on average 30 to 40 minutes. So
I was wondering if you had a dormitory, if you would help in recruiting and you could charge a little bit for living there, and it'd be a good deal for some people that they work right on campus.
You're starting to get into my crazy idea there, Representative Weiler.
Sorry.
Well, no, why not partner with a community college, erect a dormitory, and use the patients that are there as the basis for the training opportunities, and then try to produce enough clinical staff to take care of your own during training and still have others available for around the state. Turn it into a small college campus.
All we need is money.
Actually, all we need is trained personnel to be teachers. It's not an off the wall idea. We have been working with the Vermont Technical College because they're close to us over the border for the last 2 years, trying to establish a LPN program, a licensed practical nurse program here on campus. We have a building. We bought most of the equipment we would need. We've done most of the paperwork with the New Hampshire Board of Nursing. Where we have failed is for the college or ourselves to recruit a nurse with enough credentials to teach it. Most nurses that have their master's or higher are working already in the teaching field, or they're working at hospitals and things like that as teachers, significant salaries. So we have not been able to, we had one. We thought we were on the verge of opening our first class this last August, but she declined the position at last minute. The deal with Vermont Technical College was they provide all of the credentialing, they provide some of the supports, we provide the instructor, and we get 4 free slots. So we could put 4 of our employees into their program for free by providing the instructor, and we've not been able to recruit somebody. So it's not an off the wall idea. We do partner with Plymouth State University. They use us as a clinical for their nursing program. So we have students coming through regularly. Unfortunately, we don't ever really get any of those nurses because they're young and they want to work in hospitals and they want to work in med surg and they want to work in ER. They don't typically want to do nursing home level care. Some of them have shown some interest this year, so I'm hoping maybe we'll get 1 or 2 because they're more interested in the psych part of it. So we pretty exhaustively try, including every time I go give blood, I hand out my business card. Any nurse is more than welcome.
Representative Nordgren, you have a question? Yeah.
Yes, thank you. I'm worried looking at this slide that you're really lacking custodial care. With the pandemic and all the concerns we have now, this must be really hard for you to keep up.
It certainly has been challenging, and we have a couple of vacancies. So it's not a large department to begin with. There's only 9 positions. So right now we have 2 vacant, but we do have somebody in the pipeline. I believe they're starting in 2 weeks, so that number will go down. But really all of the staff have stepped up. So LNAs in particular also do cleaning, especially like the typical wiping down door handles and handrails and those type of things. But even maintenance has stepped up and done some additional housekeeping work. in some of the technologies that Joe mentioned earlier. We bought one of the ultraviolet robots that can clean a room. So we've been learning how to do it more efficiently and more specifically to the pandemic concerns. So they've been doing a nice job. But it really is a team effort up here. So right now we're hurting a little bit, and particularly on second shift of housekeeping, but I think we've got a couple of staff coming on soon. Other comments or questions on this slide? So continuing with benchmarking. So this is a slide that gives you, it's a point in time. This is the national average, the state average, and then our average for staffing. And they break it down. It's just looking at nursing and specifically RN and then LNA. This information is gathered by CMS's survey. So as any other nursing home in the state, we are under CMS regulations. So once a year, we have a survey team from the Bureau of Health and Facilities, which is also part of DHHS, come and do a full survey. They take a 2-week picture of our staffing and use it to compare it to everybody else. So while this looks like we're doing well, we're average, it's actually a little low for us because typically because of our population, we want to staff a little higher than most nursing homes. And this was a point in time about a year ago. I think right now, so if you add the 43 minutes, the 2 hours and 35 minutes, you get about an hour, 3.2. We've been averaging about 2.8 or 3.0 the last couple of months. But we're working hard to bump that back up. We maintain it again using overtime, travel nurses, and then mandating staff when we have to. But as you can expect, nobody likes to be mandated. So we try not to do that as much as possible. Questions on this slide? Moving on. Oh, I guess this is the part where I turn it back over to Joe.
Sure.
Thank you, everyone.
Thank you.
So from a financial perspective, Glencliff is pretty evenly split between general funds and other funds. Their other fund source is really Medicaid revenue. Virtually an overwhelming majority, if not all of the patients at Glencliff qualify for Medicaid. And they receive a daily rate as a nursing home. So this is really their source of funds. They don't have much of an opportunity to bill other insurances. They do bill patients or estates directly if the opportunity arises, but it's not very common. Most of these individuals are really primarily a Medicaid patient population.
If I can inject, we currently have 2 private pay. Everybody else is Medicaid.
So their general funds are pretty consistent year over year. And then the total funds of their budget, you'll see from the 2020-2021 bienniums to the 2022 biennium, not a significant increase in total funds. And there were a few prioritized needs that were created for Glencliff. It was mostly relative to wages due to vacancies. So we do have a list of prioritized needs, and I can provide that if the committee is interested in seeing those. But and did you want me to go on to the budget book now, or?
Let's do that, yes.
Okay.
Shut off.
Sure.
I'm not seeing any questions, so let's keep rolling.
All right, let me pull up the budget book. So Glencliff in the budget book starts at page 1099. It is activity code 9100, and their first accounting unit is 5710. This first accounting unit is for professional care. This is primarily all of their direct care staff and the costs associated with providing direct care. Again, we had some prioritized needs that we created for predominantly payroll lines. So you'll see class 18 in this is pretty flat. Happy to take any questions.
Representative Wallner.
Thank you. Is this pretty much what you requested of the governor, and are the prioritized needs that you had that you gave to the governor that were not funded?
Great question. The prioritized needs were not funded in the governor's phase. I heard this question come up on a few prior presentations that I tuned in on, and so I can certainly provide what those were.
They are included on the total prioritized needs spreadsheet that I provided to Kevin last week. So you should have those on that spreadsheet.
Okay. I just one further. Well, I unfortunately haven't looked at that yet. And could you just quickly maybe highlight the top, the most important prioritized needs that you had on your list?
Sure. Todd, please jump in at any point, but I think really any of the payroll lines relative to this accounting unit, 5710 direct care, I would say are the most important. And would you agree with that, Todd?
Yes.
So those were class 18, class 50 part-time staff, and I'm trying to remember the others that were in this accounting unit.
Some of it because it's payroll spills into bumping up the benefits, and it's about $500,000 total, and 400 of that is personnel related. The other 100,000 is a few things like equipment and current expenses.
I think Representative Wallner has more questions.
No, thank you. That's helpful.
Representative Weiler.
All right, thank you. Consultants, what sort of money's going up for consultants?
Would you like me to answer that, Joe?
Sure.
So on that line 46, we have a dentist that came pre-COVID twice a month. Now he comes only on urgent care. We also pay a hygienist out of that because we do have a full dental suite here at the facility. We have a registered dietitian that I believe is paid out of that line. We have a podiatrist RN that comes and provides those services. And then I think we might also have a massage therapist in there.
Thank you.
Do you have a pastor? Do you have pastoral services?
We do. We have again, pre-COVID, we have a Roman Catholic priest that comes and does mass on Sundays. And then we have a Protestant minister that also comes. And then we have a couple of different Bible groups that come regularly, again, pre-COVID. Right now, nobody comes in.
Did any of those come under this consulting line, or were they volunteer? Because that doesn't seem like a lot of money for all that extra ancillary care you're getting.
Well, most of that ancillary care is pretty infrequent. Like I said, the dentist only comes twice a month. And I might be off a little bit, like the dietitian who has a bigger contract, she might be out of 101 medical payments. But the medical payments is also where we've been using you'll see that number is awfully large. We've been using that for the travel nurses.
Do you have a follow-up, Representative Weiler, or was that? Nope, he's good. All right.
Okay. Just moving along. So 5720 custodial care.
I'm a little slow. I want to go back for a second.
Sure.
So you knew how much ancillary care you wanted, and it was all working, and then the pandemic hit, and they've essentially stopped coming. So what is the clinical outcome? What is the suffering as a result of the diminished care? Is it measurable in any way, or is it just subjective?
Mostly subjective, but it is measurable in that we've had times where we've had to freeze our admissions. So that hurts the wait list, that hurts New Hampshire Hospital, that hurts our revenue. So that's one very measurable outcome. As far as direct care for our residents, hopefully they have not been, to our knowledge, they have not been suffering medically because we continue to use overtime and mandating to ensure that they're getting the care that they need. Now, socially and mentally, they're certainly suffering this year because of the pandemic. So, you know, our residents, we have 4 units. They've been confined to their own unit. You know, they have friends in other units. They can't go outside unsupervised. So a lot of that's happened, and they can't go on shopping trips and out to dinner and things like that we used to do pre-COVID. So that has certainly affected it. With the low staffing also affects that because when we're at minimum staffing, we don't have the extra staff for those type of activities. So that's where we suffer, is the recreational, the social, you know, the cognitive stimulation suffers.
Thank you.
Any other questions?
So the next accounting unit was 5720, which is custodial care. This is where the supportive departments for things like housekeeping, facilities, etc. That's primarily what constitutes this accounting unit. The cost of that staff, food and nutrition. Again, there were some prioritized needs relative to payroll lines in this accounting unit as well. But again, if we were to prioritize them, we would prioritize the prioritized needs in the 5710 accounting unit over the 5720 accounting unit.
So is that contracted food services? If so, is that done on site or off site and brought in?
Is not contracted. They are state employees, and we do it all on site. We have our own dietary department. We looked at it, I want to say 5 years ago, maybe 6 years ago. And actually the cost of contracting it was within $10,000 of what we pay for it here back then. I mean, I'm sure it's changed in 5 or 6 years. So at that time, the decision was made to continue to leave them as state employees.
Any questions on this accounting unit?
Don't see any.
Okay. The next one is accounting unit 5740. This is the administrative accounting unit. Again, they run a very lean administrative shop at Glencliff, very few staff. And this really comprises of their core leadership structure and some finance staff.
Is that telecommunications for the whole operation, or is there telecommunications throughout?
I believe that is for the whole facility because we pay for a phone.
That is correct. It is for the whole facility.
Yeah. So our internet and computer and stuff comes through the department.
Do you have clients or patients that want to use the Wi-Fi for their own internet access?
Yes, and that's something we actually are continuing to work with DOIT on. When the pandemic hit, we had no Wi-Fi in the facility. We didn't even have it for our nurses. It's something we've been struggling with to get up here on the Hill with DOIT's approval. When pandemic hit, they were able to install 9 laptops with Zoom on it so that residents could contact their families and do some telehealth. But it is extremely limited. It can only do Zoom. Literally, the computers are locked down that they can only do Zoom, and we can't initiate them. We can only accept them. So I'm still working with DOIT to provide some Wi-Fi for the residents because they are really desperate for that kind of information access.
So just to share a story, the Veterans Home has their clients all contract separately for Wi-Fi services, internet access. And there's been a number of complaints originating from the veterans saying that they get really bad Wi-Fi service because of all of the contention in competing for the limited Wi-Fi there. So I think DOT had a solution, DOIT had a solution for the veterans home, but the commandant has other reasons not to do it. But so I just hope that, you know, given the pandemic and all the social isolation, we're finding ways to let our patients interact with the outside world, and it sounds like that's a priority to you too.
Absolutely. We actually just last Thursday received a cell phone booster that we can put on our roof, because we also don't have cell phones up here. We have no reception. So that's even more limiting. So we're trying everything we can.
Wow, it's like going back to the 1950s.
I also just want to add too, we've been researching some potential grant funding opportunities to try to bring teleconferencing, video conferencing type equipment to Glencliff for both educational and patient uses. So
Are you working with Dartmouth to do that? Because they access a lot of grants. Or how are you? Never mind. Just let's keep going. I'm sorry. I still want to try to finish in 45 minutes if possible, and I need to quit asking you questions.
So the last primary accounting unit for Glencliff is their maintenance accounting unit. Again, there were some prioritized needs in here relative to payroll, and really the rest of the accounting unit remains pretty flat funded. So.
Any questions?
Okay. The rest of Glencliff's accounting units are really relative to things like capital projects or unemployment, really things that we don't have a whole lot of control over. So that's it for Glencliff.
Do you have any big HB2 things we need to know about?
Not to my knowledge. I haven't seen anything relative to Glencliff.
Are there any questions here? I'm gonna skip over the attendees for a while, just because we have some legislators that need to cut out. So so I'm not seeing any questions from the panelists. Let's go on to the next presentation, and thank you.
Thank you very
so
much for your
much.
time.
Thank you for your attention and your thoughtful questions. We really appreciate it. We have a couple of follow-up items and we'll get those to you.
Would you still like me to call you, Representative
No,
Edwards?
you heard my crazy idea already. The surprise is over. We can
All
talk
right.
about that some other day.
All right, thank you.
Thanks, Heather. Thanks, Todd. Thanks, Joe.
Take care.
So up next is the Division for Behavioral Health, which the director of that is Katya Fox. And I believe Kevin is in process of bringing over her and her team. This division comprises of 3 separate bureaus. So I don't believe we will finish this in the next 35 minutes.
Okay, so I've heard Ms. Fox before, and she does a great job. Why don't you think about giving us 30 minutes, and then we'll have to carry you over to tomorrow, if that's okay.
Great. So just making sure everyone can hear me, if I could get a thumbs up on that. All right. So good afternoon. My name is Katya Fox. I'm the director for the Division for Behavioral Health. And I have a team behind me that is ready, willing, and able to step in and answer questions as they arise. Given the fact that we only have 30 minutes, I think what we'll do is we'll try to get through one of the bureaus, but I'm not sure if that's going to be possible based on the questions that you have and the enormity of the division and the division's work. So Jane Jackson is our finance director, and she reports directly to Karen. And I am in my office in Concord, if that matters to anyone. So what I want to do is just talk a little bit. So this is the agenda. You've seen this now several times. The division. So the overview, it's was created 5 years ago. And the idea was to bring together behavioral health services and supports at the community level. So this morning you heard from New Hampshire Hospital, which is at the acute psychiatric level, and then you just heard from Glencliff, which is more the long-term services that are needed in this system. And so we're really focused on the community-based systems. And that includes, there's no vision or mission statement here. However, our driving forces right now are all about systems transformation. So in the middle of a pandemic, we're trying to transform our systems to better address the needs of individuals and families who are struggling with behavioral health issues. So we had the Bureau of Drug and Alcohol Services, and I'm going to give you little buzzwords as a way to cue you so that you know when you hear something in the news, you know what how it relates to this presentation. So for example, opioid overdoses and opioid deaths. That's what you would commonly think about when you hear about the Drug and Alcohol Services Bureau. They are working very hard. We are all working very hard on a action plan that was developed. It's a 2-year action plan that ends at the end of this calendar year. And it really focuses on addressing the need to reduce the incidence of deaths and the misuse of alcohol and other drugs. For children's behavioral health, you had a lot of conversation about that this morning. That is also undergoing a significant systems transformation, and that is really known and governed by the system of care, another buzzword that you hear about, and we're going to go into more details about that. And then the 10-year mental health plan. So that encompasses both children and adults, and that is governing a lot of the work that we do. And most importantly for this particular committee, it is where a lot of our funding is directed. So you're going to see some growth in funding, and that's because the need is so great and the opportunity is really standing before us to continue to transform the system. We don't want to just keep adding services and nibbling at the edges. We want to rethink of everything that we do so that we're not just expecting to add and add and add to a system that's already stressed. We want to transform that system and have it be more responsive to today's needs. So the first unit you'll see is the Behavioral Health Policy Unit. There are 6 of us in this particular area, and it's division-wide. And this is really the area that provides technical assistance to not only within the department and within our division, but also with stakeholders. So a lot of this work and these positions are focused on grant writing and Medicaid policy. We've had the, you'll be hearing more about in the Medicaid presentation about what you probably are aware of, which is the integrated delivery networks in the 1115 transformation waiver that has been going on for 5 years. And there also is legislative work. We have a person who's dedicated to being our legislative liaison and working with all of you on important initiatives for our system. So this is just within the division. This isn't the entire division, including all the bureaus. This is just in this accounting section. And again, you'll see some growth there. And if you have specific questions, Jane Jackson can answer them. But what you'll see is that those federal funds are part of an interagency transfer that actually directly relate to New Hampshire Hospital and to Glencliff Home. And so you'll see where those funds are for Medicaid payments that go to those two facilities. And then the rest of it is the staffing and the ancillary required financing for that. So I put this slide really early on so we could cut to the chase about the prioritized needs. And then we'll go into it if necessary as we get into the various bureaus. So additional guardianship slots. We have guardianships that are required under law. And these are typically individuals that you may think of at New Hampshire Hospital who need assistance and help in managing their finances, for example. And so a guardian will be appointed by the court. And I have the numbers, I won't go over them now, but this would provide for an additional 10 slots for that. So that was one of our prioritized needs that was not funded. And
Wait, hold on a second.
Yeah.
You can get 10 slots funded with $30,000, or is 30,000 just the additional amount that you need that you didn't get?
so it's 10 new slots for $30,000, believe it or not. The rate is very low because typically those guardianship services aren't very labor intensive.
Just a surprising amount, but all right.
And then the other prioritized need was $1.5 million for stabilization services. As we look at streamlining and transforming our emergency services response, and that gets into Representative Wallner's comments, and I believe Representative Nordgren talked about mobile crisis and was asking about mobile crisis. So we're transforming the approach that is currently used. Again, not adding services and expecting more and more and more, but really re-looking at how we provide those services and where. And so this funding would have supported that continued effort.
So Katya, before you jump into the bureaus, if you can just go back one slide. Chair, would you like to go over these 4 accounting units which are related to the division as a whole before we go into the bureaus and the bureau information?
Let's go ahead into a bureau because this sounds like it's fairly routine. This
Yes,
area.
they are pretty straightforward accounting units. Okay.
All right, let's see.
I was going to ask Mrs. Fox which part of DHHS she thinks we should get that 1.5 million a year, but I'll not do that.
I would defer to Commissioner Shibinet and CFO Rounds on which area should get those funds, but this is particular to our division. So the Bureau of Drug and Alcohol Services, the aforementioned. So it's a single state substance misuse authority, which is designated by the federal government. We have to have a single state authority for drug and alcohol services, and we also have one for mental health. And so this one is for the drug and alcohol services. And this is essentially the slide that shows the services that are provided. And so you start with prevention. And I know you're going to be talking a lot more about prevention when it comes to public health, but also from the other divisions. Crisis and acute services. So we think about, everyone knows the word detox and that kind of, and mobile response, which also occurs in the SUD arena. Outpatient and residential treatment, I think we all know what that is. Peer recovery support services, very critical to the work that everyone does in ongoing recovery from a substance use disorder. And then family support services, which I know that we've seen Ken Norton a couple of times, and know that family supports are also a critical piece. So what do those areas entail? And so we have prevention and education and population level prevention. I'm just going to go and look at my cheat sheets. The information that I'm providing is also detailed much more in our briefing book. So if you have some questions, especially since we're unlikely to finish the entire division today, sorry, Chair. I don't think it's going to happen, but it may give an opportunity for you to be able to look in more detail at what I'm presenting this afternoon.
A reasonable goal to finish this bureau before shutting down for the day?
I think it's reasonable. And what I want to do is get to the questions rather than just prattle on something that may not be of interest when you may have specific questions. So to the extent that I can accommodate that and really go with the flow, just let me know.
All right.
So population level strategy. So that's really looking at community mobilization and engagement, promoting healthy behaviors through social media and through other means, and increasing awareness about access and the services that can be provided. Direct prevention, which gets a little bit more detailed into people who are at risk or may have already been engaging in substance misuse. And then, and I can give examples of those if anyone wants to know what those are. And then when we get into surveillance, this is where you hear, I know that it used to be a lot more common that you would see a news story where there would be the liquor enforcement would do those checks and really determine whether minors were accessing alcohol through that means, through purchase, through whatever means that may be. So there were those checks that happen. And also surveillance includes drop boxes, which we're all familiar with and have really increased over time. Crisis intervention and treatment, very, very self-explanatory. There have been millions of dollars that have been afforded to the state through the state opioid response grant. And we've been deploying those services through what you know, and we'll get into this a little bit more, as the Doorway program with the 9 doorways across the state. We've had treatment services. And so this is your traditional thinking about residential treatment, which includes, say, for example, Farnham Center or Phoenix House and Southeastern Services. Those are the inpatient services that we provide, and they're at different levels of care, and the outpatient treatment. So that's part of what's in this treatment box. And then impaired driving. We always forget that our bureau is in charge and overseeing the impaired driving program. And again, for your purposes, we talked about people paying for services when we were talking about New Hampshire Hospital. The individuals who are court ordered into this particular program pay for the program. It's a self-pay, and so therefore it is self-funded, so to speak.
Do their payments exceed the costs? Or are you making a profit, in other words?
I don't believe that we're making a profit. I believe that it is a break-even situation.
Government is generally not permitted to make a profit. So I think.
Well, we call it something different, but that there's a surplus of funds that are reallocated to other cost centers.
Right. No, that isn't the case in this situation, to my knowledge.
And then the supports that are provided, as I said earlier, as people go through the continuum and go through recovery, And that includes the recovery community organizations, which are overseen by a facilitating organization that provides all of the administrative support for these organizations. I believe we're up to 14 to 16 of these organizations across the state. And again, to orient you, we have SOS on the Seacoast, and we have Navigating Recovery in the Lakes region, and a number of other organizations that cover the entire state. Hope for New Hampshire Recovery in Manchester and Berlin. Those programs are providing peer support. So rather than having a medical model, it is a model that's nationally recognized and supported mostly by volunteers. There are some paid staff, but there are many, many people in recovery who want to give back, and they act as peer coaches with these organizations. We have family support services. These are support groups that are held throughout the state for families. And then recovery housing. And so we have been able to, over the last couple of years, put in some standards for recovery housing. And there is actually a statute now that only ones that have gone through this certification process are able to receive state funds. So we tighten the controls. There are a lot of concerns about standards for this particular level of housing, and those have been instilled and tied directly to state funding.
So is there a supplementary slide also in this deck that deals with all of the metrics of success, how you're determining how successful you are, or what kind of workload you're dealing with?
I would say there's just a sampling. There is not a detailed, we can provide additional information, but it was way too much to include in a compressed time frame.
Okay, if they don't already exist, it just may be a good homework assignment over the next year or two.
Sure, and we've been working very closely on that and really focusing on outcomes and evaluation. Both of the state opioid response grant dollars and grant funded programs, as well as our other programs. So we have a lot, they're just not in a nice, neat package, but how about we share what we have and then let you know what our plan is going forward.
Great, thank you.
So 125 contracts. Anyone who has gone through a contracting process with us understands what that takes, and also what it takes to not only contract and go and get the contract in place, but then to oversee those contracts. And so we are statutorily required to carry out the decisions of the Governor's Commission on Alcohol and Other Drugs. And they alone, I believe, account for maybe up to 50 of those contracts. And what we're able to do with the Governor's Commission funding is braid it with federal funds and with state general funds to be able to support all of these services that you see listed here.
So to what extent are these actually unique contracts versus model contracts that have minor changes between them?
So that's a really good point because it makes it sound very daunting. So for example, the treatment contracts, many of those are the same contract. That's only, the only difference may be the amount of dollars that are awarded in it. So that's a core contract and then toggled to address population and other needs in the community. But it's still 23 different organizations that we're interacting with and overseeing and managing and auditing and
monitoring gets to be the bigger part.
Absolutely. It's really important. And I know that you had Meredith Tellus here from Quality and Performance, and she talked a lot about what is done in that arena, and we work side by side with her on that. So again, I said that there would be a little bit of data that we could provide. So this is individuals served. And if you want to dive deeper into how do we get to that 80,000 number, I'd be happy to share that with you. Prevention is an area where you see where you make the investment, that the reward is great, a return. And I know studies have been done on that. And so the more people that we can reach on the prevention end, the less number that we have to treat on the acute side. So again, the doorways, this is interesting data because you see some dips, and as many of us have already been talking about, we've seen changes and some anomalies that we wouldn't have expected to see due to the pandemic. So we're very pleased that the doorways were able to maintain contact with individuals that they were already serving and keep their doors open, which may mean keeping their telephone lines open through telehealth to be able to continue to serve individuals. And so we saw a big dip, and now it's starting to come back up again as we all struggle through and learn to live with the reality of the pandemic. This is also very much tied to the pandemic on the number of people who have been able to be in treatment services. And again, it either is because of closures or not closures, well, closures on a temporary basis, where we had to reduce the census in the provider system for social distancing as people were in treatment, trying to maintain them in treatment while dealing with all of the issues that they needed to deal with through the pandemic. So we saw those admissions go down. As you will hear, I think, from the advocates and from me right now, we anticipate that the demand is going to get very, very high in all of the services that we provide through our division. And so we know about the liquor sales and the increase in that. We know that there are many, many children who are in crisis and for not being in school and having their social supports. And we know that people have prolonged their interaction with our services because of COVID. And so they come in at a higher, in a more acute level. So we're just getting started with our pandemic response. And again, this was a very successful endeavor through the pandemic, where we've seen the increase in growth of peer recovery support services. And we've been able to do that with funds that have been afforded through legislative action, as well as the state opioid response and critical dollars from the Governor's Commission that have supported these organizations. How am I doing on time here?
You tell me to get through this bureau. I think you're on pace.
Good, great. So these are the positions. One of the things that I'm sure you've heard about is that we did have a hiring freeze as we were worried about state revenues and what that was going to mean. However, that has since been lifted, and we're in the process of filling these positions. So we were shorthanded and will continue to be shorthanded until all those positions are filled. And then these are just a couple of benchmarks. They're not the ones that I think that you were speaking to, Mr. Chair, but they are achievements that we've been very pleased with, but we have a lot more work to do. So the student assistance programs, they engage with youth to provide prevention and early intervention services, and typically right in the school setting. And they were able to continue to have that contact with students in very creative ways as schools went remote.
So this is a new slide that I've requested, so I just thought I'd let you know what I was thinking when I asked for this sort of thing. And the way it's been presented in other DHH slides is that on the left, there are the things that drive your workflow, what metrics or client load drive your workload. And then on the right, what quality measures you're using to make sure that you're doing a good job. So the one on the left is how much work. The one on the right is, how well are you doing the work?
Okay. So that doesn't quite hit the mark on this. I'll go back and look at some of those.
No, it's in the the horseshoe range.
Okay. All right. Quality is always an area that we're striving towards. It's something that we all expect, and something that we owe to the people that we serve, and it's something that we continue to work on. And then again, the availability and engagement in peer recovery support services. So as you saw in the previous slide, we're growing those services and want to continue to grow that system. So key accomplishments. We have seen a decline in overdose deaths at a time when other states have seen increases. So we feel that we're making progress, but any death that is due to an overdose is one too many. And we're going to keep going and going and going on that and not take our foot off the pedal. And we are able to very rapidly, just as the state employees were able to quickly, and I think Dave Wieters probably talked about this, go to remote work. We've been able to work with our providers who've been amazing in being able to make sure that they could maintain services and keep in touch with the clients that they serve. So there's more doorway information. They distribute naloxone. That has been critical in addressing the overdose deaths, that intervention has made a real difference. Let's see, I'll just trying to go through this quickly so that we can move through.
About 10 more minutes. Just about 10 more minutes.
Okay, so for prevention, one of the things that the Governor's Commission decided to do when its funding was increased in the last biennium to $10 million per year was to invest in prevention, because that's the area that we all have to look to when we're making really tough decisions about budgets. And so they did a investment that they referred to as double down on prevention. And we're seeing the results of that. So ASAM, so the American Society of Addiction Medicine, is a criteria that sets the level of care. And that is a state requirement in how we all work to determine how long and what type of treatment someone needs as they enter into the system. So we used to call them 28-day programs and similar time-stamped programs. Now we look at the ASAM criteria and determine if someone can move through it more quickly or needs more time to get through that stage in their recovery. And then this is an IT area that we've looked at for the recovery community organizations. Challenges, as we all know, that there continues to be the lack of community acceptance in some areas in substance misuse services, which then impacts our providers' ability to stand up services in particular communities. There's workforce issues. Not the first time you've heard that, not the last time you'll hear that. And then the rapid growth of the continuum of care. So while we've been very grateful for the funding and the support to grow and transform this system, it requires a lot of work and a lot of work from a lot of people. And so that's been a challenge as we've taken this on. Budget. So I'm going to linger on this and ask if you have specific questions.
So I would just mention here the 2020-2021 in the middle there, you're seeing the general funds at 6 million and then go to 8.4 in 22-23. It's not an increase in what has been budgeted because 2020 is showing actuals there and not budgeted. If it showed 2020 budget and 2021 budget, what you would see is that $6 million number a lot closer to the 8.4. Like many programs in 2020, there has been delays in funding because of COVID.
And then I'll mention,
Big jump in federal funds. That's nice. What's that?
so that almost entirely is attributed to the state opioid response funds. So we received significant, so right now, for example, in this federal fiscal year, we got $28 million. And we also had carryover funds from 20. So that's where a lot of it comes from. We also receive the block grant. So SAMHSA provides a block grant for substance misuse as well as for mental health. And that is $7.2 million. We have received word that we're going to get more funding, but have yet to receive the guidance or the notification. And we'll be needing to bring that forth at some stage in the budget as we go forward. The other thing I wanted to point out is other funds. So that's a huge number. It's obviously much bigger than general funds, and that is primarily the Governor's Commission funds.
The Alcohol and Drug Commission, the 5% from the alcohol revenues, is that, or profits? Is that what you're saying?
So Karen, do you want to handle that or you want me to?
Sure, I can touch on that. Yes, but the funding is actually donations from the hospitals.
Oh, that's a different thing. Okay, so Representative Wallner, did you give up on me or you still have a question?
No, I'm set. Thank you. She answered it.
My question is this rather significant increase in federal funds in the next biennium. Do we have reason to think that they'll continue into the biennium beyond this, or is this kind of one-time money? Do we know?
We don't.
We don't know. We don't know. You know, New Hampshire has done so well in the state opioid response that we need that funding to continue that momentum. However, the funding formula under state opioid response has been based on our numbers and how many overdose deaths we've had. So hopefully that formula doesn't change and that we'll continue to be able to receive these funds, but that is really a subject for Congress to tackle.
Any other questions on this slide? You want to go on?
Okay, the good and the bad. So if we were to get a 5% increase, I would emphasize the bottom one on that the top three. So rather than focusing on BDAS staff, which is really, really important, as you can see from what we're required to carry out, but I think it also looks at sustaining the new initiatives. So your point is, you know, is that federal funding going to continue so that we can sustain the current structure and the current system? The 5% would help us in that arena. And then The workforce development, again, you've already heard about that quite a bit, and we'd be able to continue to invest in workforce. So the bad would be that we would reduce staff, and we would need to look at cutting existing programs. For example, some of those contracts that we talked about that are funded through all those graded sources, we would have to look at those and the general funds that are committed to those. And I'm not sure if those would be able to be sustained through federal funding and through the Governor's Commission, which are very hesitant, the Governor's Commission, to invest in anything that the state is not supporting on its own.
Sure.
And also, I'm sorry.
No, finish your thought. Go for it.
I just wanted to say we do have a maintenance of effort requirement for our federal block grant, the 7.2 that I mentioned. So we always have to look to make sure that we're meeting that.
Yes, that's critical. So my general observation on this slide is these are nice concepts, but I don't see anything measurable here. So I don't know how to evaluate what these words mean in terms of practical results.
Be happy to come back with something more definitive if that is your pleasure.
I think we'll need it because every program is going to have to really be looked at from this perspective, and the better each program is able to articulate something that can be measured, I think it just makes their argument stronger.
Yeah.
That's my thought, but every committee member has their own. So, all right, what else do you have for us?
We could take the actual dollar amount and then really drill down on that, of what that 5% could mean. So here are the accounting units, and this is the last slide for this section.
We have a couple of minutes to look at an accounting sheet. Does somebody have an accounting sheet for us to look at, line items?
So Katya, if you want to stop sharing, I'll go ahead and share the accounting units.
If I could just break in for a second here, I'm not sure if you saw the email, Representative Edwards, but the Gopher meeting has been postponed until Friday, so I'm not sure if that changes your plans or not.
It could. It depends on if Representative Woolner and Weiler were looking for an excuse to leave.
Well, we just lost our excuse.
Thanks, Mr. Ripple.
Thanks.
We've got to get through this one time or another. If that Gopher meeting's on Friday, fine, we'll keep going.
All right, let's go ahead. Let's go ahead and look at the accounting numbers.
Great. Okay, so we're going to start on page 1108, which is accounting unit 2070. And I would just mention that Jane Jackson is also on the line. She is the finance director for the Division of Behavioral Health, and you will also see her with the Division of Long-Term Supports and Services. So
I want to say hello to Jane Jackson because I haven't seen her in about 25 years when she worked at Rockingham County.
It hasn't been quite that long.
We did steal hair from Rockingham County and are very grateful for
Jane
that.
knows the numbers very well.
Yes, she has been a great addition to our team. We're very thankful. So accounting unit 2070 is program operations for Bureau of Drug and Alcohol Services. So this is where the bureau chief, it's the administrative accounting unit, if you will.
Can we, on this one, go down to the personnel leveling from budget to budget? Right, yeah, right in there. So we've got a plus up of just one.
Yes, and I believe that I provided all the detail to Kevin of all of the position moves throughout the department.
So is this a position move or is this a new creation?
Was this a conversion, Jane, or was this a move?
This would have been a PS4 that's new for help with recovery initiatives.
So was it moved from somewhere else though, or was it a temporary position that we converted to permanent?
I believe it was moved from 78, 77. We had a few positions that were budgeted in the main 9,200, which we kind of briefly went over and skipped the accounting information on. And one of them ended up in this division.
Okay, yes, so it was a move.
Questions from the committee on this area? This looks pretty straightforward. It's being driven by the FTEs for the most part, right?
Yes.
Okay, we can continue.
Okay, that accounting unit's not being used. 3380 is the next one, which is prevention services.
So the total almost doubles, right? Am I reading that right?
Yes, and that looks like it's because of agency income. Jane, where is the agency income coming from in this accounting unit?
The agency income in this accounting unit is from the settlement funds. Not sure if you want to talk a little bit more about those, but that is where we budgeted for the settlement funds. And you'll note that in an upcoming accounting unit, 3395, which is our PFS2 grant, it's coming to an end. And so some of the contract initiatives that were taken care of with that grant funding have been moved to prevention services. So you'll see a jump in the contract line. Actually, now it's up in line 074, which is where we moved some of our contracts to a grants line if they were considered a subrecipient. So you'll see a shift from contracts in 102 from the prior year, shifting up to 074 grants for public assistance. That you'll see an increase there, and that's what that is accounted by.
So the settlement money, is that opioid settlement? It's not tobacco settlement, right?
No, not tobacco settlement, opioid settlement, which are, go ahead.
So that's a new source of money relative to the past budgets?
It's a new anticipated source of revenue. There are several, I believe, lawsuits, Katya might be able to speak to it better, related to opioids and anticipated funds that will flow through to the state. There is a opioid abatement advisory commission, for which I am the designee of the commissioner to sit on. Actually, our first meeting is Friday morning, which is why we're starting a little bit late on Friday morning. And that committee advises the department on how to spend the funds. So this is an area that we sort of are hoping to be able to do that. Ultimately, the commissioner makes the final decision on how those funds are spent, but that commission advises on it. So this will be something that we'll be discussing with that commission as time goes on.
For that settlement money, do we have a state matching requirement for any of it that we know of?
Not to my knowledge, no. It's not a grant, it's a lawsuit settlement.
I'll just point out that the state has already received one, or at least it's going to be receiving some funding from the McKinsey settlement. And so you'll hear names of the different manufacturers and different players that have been sued over the opioid epidemic. And so there already is a chunk of funding, and we anticipate receiving additional funds, hopefully this spring as we're developing the budget and settling on the budget.
Any other questions on 3380?
Not seeing any.
Okay. And we'll move, just make sure I'm going to get Governor's Commission funds. Right here, 3382.
Are these the alcohol revenues?
They are not the alcohol revenues. They are donations from the hospitals.
Okay, so, all right. So you already said that once. I thought that was in a different section.
Nope. So I think the alcohol revenues that you are thinking of, those go into a Medicaid account.
Karen, I should point out probably, they do pass through us. They do pass through.
Yes.
us, and then they get transferred over to the Medicaid division.
That's a good point, Jane. Thank you.
All right.
Okay. The next accounting unit here starts at the bottom of this page, 3384. I need reading glasses. I have not been to the eye doctor since COVID. 3384 and continues on to the next page.
I'm having to lean in so much to see the numbers that people can do an ophthalmology exam over Zoom for me.
That would be great.
Yeah. It's coming. Okay. So this is relatively level funded.
Yes. The major change here is the one that we've talked about in a couple other presentations where we're moving it from 102 to 74 for better tracking purposes for the single audit. Yeah.
All right. Are there any questions here from the committee? Seeing none, we can continue.
The next one is 3385, the drug forfeiture fund.
Forfeiture fund. What does that mean?
Katya, do you want to, or Jane?
Just a sentence or two. What is a drug forfeiture fund?
I'm waiting to see if Jane responds. So that is transferred from, I believe it is the Department of Safety. Jane?
I think it's Department of Justice, I believe. I'll have to check back, but I do.
That's right.
Is this tied to the civil asset forfeiture? So if we bust a drug dealer and take their property, that's what this money is?
Exactly. It's a percentage of that that's to come to us. Yes.
All right. Thank you.
Okay. And then starting at the bottom of the page is 3393, which is the treatment drug court grant, which I believe ended, so it's no longer budgeted. So then coming down to 3395, which is the PFS 2 grant, which Katya was speaking about earlier, that ends during fiscal year 22. So we have moved that budgeting in 23 up to that previous accounting unit where you saw the increase.
Okay. I'm not seeing any questions here.
Okay.
We can go.
All right, moving down to 6935, which is the MAT grant. That also ended in fiscal year 21, so that is no longer budgeted.
What does MAT stand for?
Medically assisted treatment.
I believe we now use some of the state opioid response funds for some medically assisted treatment contracts, which is also the accounting unit on this page here, which is 7040.
So that might have been how we paid for Narcan and stuff. It's all right. I'm just talking. Let's keep going. 7040.
Yes, this is the large grant that we were mentioning is what increased the federal funds across this bureau. We have gone to fiscal committee for fiscal year 21 already to accept those funds, and then we are budgeting them for 22 and 23.
So it seems to me like the finance committee, Division 3, that we probably need a decent understanding of what is driving that dollar amount and how predictable we see that amount in the out years, and whether or not we need a state match at all for any of that. Is it, and is this subject to that level of effort of 7.2 million, or was that something else?
So, Mr. Chair, that was something else. That's our core funding that we've received for years and years and years. That currently is about $7.2 million, and that's our block grant. SOR funding does not have any maintenance of effort or match. It only cannot be used to match Medicaid. So we can't take the funds and then, a Medicaid expense for opioid treatment and then use these particular funds for that. It has to be something that could not be funded otherwise.
Okay, and so the plan for this is primarily there on grants for public assistance and relief.
So again, that
Okay.
class line 74 is the one that we're using to represent subrecipient monitoring. You remember we talked about that last week, that the Department of Administrative Services was unable to create a class line for us that said subrecipient. So that was the class line we used that we've not used previously that made the most sense.
So just remind me in a sentence or two, what are we paying for with that $25 million?
So I'd be happy to. So you mentioned naloxone. So we're buying naloxone and spending a considerable amount on that. We also stood up the doorway programs. So any non-Medicaid billable services that may involve what staff are doing, the rent, all of the services to have those doorways open and ready to go. As part of the doorway system, they enter the system through 211. And so we have these 9 doorways across the state that are open typical business hours. We have a couple that are open on weekends. And then we also have after hours coverage so that there is 24/7 access. And that includes clinicians who are available after hours. We also provide, as I said, the funding for the recovery community organizations. They're funded out of that to quite a considerable amount. We have medication assisted treatment. That is a Medicaid billable service. However, there are individuals who still remain uninsured or underinsured. And there are many services that are supporting medication assisted treatment that are not Medicaid reimbursed. I'd be happy to share with you our grant application, which was awarded, that has all of the individual components that make up that 28 million.
Do it in a half a page, or are you going to send me a 400-page document?
I will send you whatever you would like. I could.
More in the half-page category.
Okay.
25 million is a decent chunk of money. I'm just curious, if I imagine you're using it well.
We are stretching it to the extent that we can. And one thing I should note is that the previous opioid response grants were only to assist individuals who were addicted to opioids. And now they've loosened that up to stimulants as well. And you may have seen a recent news article and a lot of talk around different tables about the concerns that we have about the rising use of stimulants in the state.
I did, actually. Representative Weiler?
Thank you. We've had a few pages here. Excuse me. We had a few pages that didn't have any class 10, but they've got the class 60 for the benefits. Is it all temp full-time people in these?
Yeah, so it would be either temporary full-time or temporary part-time. And this, on this accounting unit, it's temporary full-time.
Why did it get, is that because it's fairly new program and you haven't settled things out yet, or what's the reason to have it full-time?
Yes, we try not to create permanent positions unless we know that it's permanent funding. So we leave it as a temporary position if it's temporary, what we think could be temporary funding. So in this case, we would not make them permanent positions because we don't know if it's permanent funding.
I can remember in conversations in the past, somebody said, well, we got somebody in our office for 20 years and he's always been temporary full-time.
I understand. And sometimes it's because that, you know, every Congress does end up renewing the grant, but it isn't for sure.
Thank you.
You're welcome.
Are there any other questions from the committee? Okay, we can go on.
So that's actually the last accounting unit in BDAS. So I'm not sure if you want to switch over to Katya and do the next bureau.
Yeah, we still have 2 more bureaus, right?
Yes.
And what, does it make more sense to you to do both bureaus and then the accounting, or just like we did before, do the bureau and then the accounting?
Do the bureau and then the accounting.
I'm sorry, I was trying to find my unmute button. So typically I fill dead air. So if you hear dead air like that, you know that I'm having some technical difficulty. All right. Bureau for Children's Behavioral Health. I think this is going to take us a considerable amount of time because I want to address all of the questions that you have. And so, Kevin, I think that we're going to need to bring up Erica Ungarelli. We don't need to initially, but I think the level of conversation that was to be had this morning will necessitate her participation because she really has the subject matter expertise and the knowledge about this system and what we're trying to achieve.
So while all that's happening, and if it's going to take a lot, let's go ahead and take a 5-minute or so bio break. And you guys can get everything staged and ready to go. I think we can wait for Karen and Ken. Okay. I think we have a quorum. Representative Weiler's not back yet, but I think he can catch up.
Katya, something strange happened with your screen sharing. I'm not
I
sure.
know.
Maybe if
I
you
don't-
stop share and try again.
Okay. It's gonna do it again. Let me, just give me a sec. You know, Chris Santinello had Dave Wieters walk by, so I don't have the luxury of him being right across from me. There we go. Is that better?
Yes.
Okay, I can't see any of you, but I'm sure you'll stop me when you need to. There we go. Okay, so the Bureau for Children's Behavioral Health. So we talked a lot about, I should say that the Bureau of Drug and Alcohol Services serves all populations. The Bureau for Children's Behavioral Health was created right after the division was formed. So it was established in May of 2016, so not quite 5 years ago. And the idea was to really elevate the children's issues by having a very intense focus on children's behavioral health needs. And so the Bureau looks at children, youth, and young adults up to 21. That's a key piece. And they have been identified as having a behavioral health concern and requiring services. So the Bureau oversees the publicly funded programs to treat children and identify them, as well as to provide those services and support the families. Again, as we talk about this, those family supports are really important. And then the Bureau also, as all of us do, oversees the contracts and service providers in the system to ensure that they are being responsive and we are being responsive to the population needs. And so, as I mentioned on the outset, that this is really governed by the system of care values, which were established through a very, very robust stakeholder process. So Erica created these slides, and I think it's really talks about over the last 5 years, the type of growth that we've seen in this area. And it's been exciting and daunting at the same time. So we started off with 2 staff members, and then they had their particular programs that they worked with for the funding that was allocated, and then the initiatives that were going on about 5 years ago. 2 years ago, we doubled the staff size. That's a big number, except it's small. And we started adding some additional initiatives and some different accountabilities for this particular Bureau and its expanse of the work that it was doing. I'm sorry, I might be going too fast. Here we are today. So we've essentially doubled the staff again in recognition of all of the work that was going on and the opportunities that we had to really fully build out that system of care. And so we have, as you've seen through all the slides, the 10 community mental health centers. And I apologize for any acronym. I had communication with Erica earlier. I'm like, remind me, what's this, what's this? So if you have any questions about any of them, please let me know. And so then we have care management entities, and they provide intensive in-home supports as well as peer support. We have grants, treatment providers, peer providers. We have an assessment tool that's used to look at the strengths and needs of a particular child and their family. We are in the process of the mobile crisis implementation that was mentioned earlier today. We have in-state residential treatment providers, and we've developed an infant mental health plan, knowing that the earlier that we can start addressing needs, the better. There are so many major initiatives that are going on, and they may look like they're separate and distinct, but they really are part of that system of care. And so I'm going to actually skip right
So
to
Kansas an IT system, that's the clinical assessment system?
it is. It's web-based, I believe. Is that correct, Erica? Is Erica on?
That is correct.
Hey, Erica, nice to see you. Erica, again, the director of the Bureau for Children's Behavioral Health.
Representative Wallner has a question.
While we're here and I see mobile crisis units there, what has been the delay in getting these? And we gave you in the last budget, did we give you funding for 2? I can't remember how, if it was.
I'll explain, and then Eric can talk a little bit about that. So we've had 3 mobile crisis units in the state, and I'm going to go right to this one because you'll see statewide mobile crisis right here down at the bottom. So we've had those. They were established as part of the Community Mental Health Agreement, which was a court settlement known as Amanda D. And we're required to set up those 3 teams in Concord, Manchester, and Nashua, and we've done that. It has been abundantly apparent that to address children's needs and to address adults' needs, families' needs, all population needs, that mobile crisis is the most effective way to intervene when someone is experiencing a behavioral health crisis, so that they don't end up in the institutions that we've talked about. So they don't end up in the emergency departments. They don't end up in need of the Hampstead Hospital, for example, level of care, that we have that intervention in the community. So everything that we do, we in most circumstances want to do in the community. There's some circumstances where it can't happen. So that is the model. So as part of SB 14, the idea was a statewide children's mobile crisis response. We looked at the funding, we looked at the workforce, we looked at the provider capacity, and we determined that we could not just stand up a children's mobile crisis and ignore the rest of the family, ignore the fact that there really should be access for all populations to mobile crisis statewide. And I know that our friend Ken Norton would be happy to talk about this because he's been someone who supported this from day one. So what we did was we developed the model of what that would look like. And that doesn't include just, okay, stand up a team and they go and do this work. That is part of the transformation that we want to achieve, which is to have emergency response. And so typically emergency services happen in the emergency department. And so that's typically where people are getting that intervention. The idea is to transform that and have all those interventions, with the exception of the few that are needed, happen in the community, happen in people's homes, happen in different community settings, happen in schools, happen at perhaps the police department's involved, but to have those happen there and not in that emergency department where treatment's delayed and a whole bunch of things cascade and do a trajectory that is not necessarily the outcome that we want to see for these children. and for adults as well. So the delay. So we were, again, affording money and having a system be able to respond to what we are looking at is a rehaul of our emergency response. It's just not a matter, again, of standing up a team. You hire a couple of people and they go around with a van and say, we're mobile response. We have an RFP that was issued. We're in the process of getting that finalized for a centralized dispatch center, so to speak, that can provide statewide coverage with one phone number instead of the hundreds of phone numbers that we have out there. When someone wants to call their community mental health center or call some provider and find help, there'll be one phone number for them to access and determine this particular entity will be a hub, so to speak, and be able to dispatch in the community and do that screening and assessment initially, so that we don't bring out the police if the police don't need to intervene. We don't, overburden a system. We really determine what that level of need is in that initial screening. And then we have the regional teams that are able to respond based on what the need is. So there may be resolution through telephone, and there may be resolution through that in-person face-to-face. So that has been our vision, and that's what we want to see. However, we had a pandemic. And throughout that pandemic, we did everything we could to really hold together a system that was fragile. So we had workforce issues prior to the pandemic. We have workforce issues today. We have readiness for our providers to be able to stand up these services. And we also had the procurement process, which was also delayed because our contracts unit, which I can't remember if you've had that presentation yet, they were down staff. They had a huge vacancy level, and they had hundreds and hundreds of contracts to execute for pandemic response. So all of those informational items that you see on the Governor and Council agenda, they were behind those in for the department in getting those contracts in place so that we could get all of the emergency services we needed to respond to the pandemic. So it is not for a lack of money, and it's not for lack of hard work by Erica and her team and all of the people that we work with. It's just was a matter of trying to transform a system when we had an earthquake, and we're just trying to fill in those fissures instead of and really stabilize it. And we're still trying to stabilize it. We still have residential providers who have quarantine issues. They have bed space capacity issues. They have staff that are out. So I get pretty passionate about the fact that we're getting criticized in many, many fronts for not having this stood up yet, but there are so many factors that go into that. And we are doing everything we can, and we're still on track to be able to go into contract and have this ready to go in the next several months.
Could I ask one further question?
Yes.
So right now, did I understand you said we have 3 that are operating, and they've been operating for a while. I don't know how many years, but quite a while, right?
Yes.
And you're authorized to contract for 2 more. Is that right?
No, we're just to have statewide mobile crisis. There's no number on that. We just have to have statewide coverage.
Okay. So
and we're looking at transforming the system. So when we think about it, it's not exactly the same model that we saw in Manchester, Nashua, and Concord. It's a different approach to responding to acute needs.
Okay, thank you.
Mr. Chair, any additional questions?
I'm not seeing any, and I have trivia questions to ask you, but I'll let you continue.
Okay, I'll let that pass and keep moving forward. So this is really a slide about the system of care. It talks about the different levels of care, which is something that we're in the process of implementing through our procurements. We've had many procurements. The result of taking this slide and operationalizing it. And so when you look at, trying to just pick one out in particular. So we've had a series of the initiatives that have been put in place. This is system transformation that requires building blocks. You can't just start anywhere and just start throwing it out there and say, oh, this is the easiest thing to do, so let's go procure for that. This really had building blocks. So hiring Erica's staff was a building block because we needed to have the wherewithal and the ability within the department to move these initiatives forward. And so then we had COVID, and it needed to stand some things up pretty quickly. One was the care management entity for the Fast Forward program. And Fast Forward, FAST is families and systems together. And it's a high fidelity wraparound model that's used to address children's and families' needs. And one of the major levels of effort is the levels of care. So there was the establishment, and this was done with hundreds of stakeholders who participated in this process and helped inform the levels of care for residential treatment. We often find ourselves not having the level of care that we need in our state. And so individuals we've had to work with other states to find placements to get the right level of care. This is a procurement that is currently out. I believe it closes within the next couple of weeks. And so we have these levels that will then be able to provide the right level of care at the right time. And you had mentioned earlier, I believe we talked about the children's level and what is needed. This psychiatric and hospitalization piece is the step down or step up. It's just below the level of care that we've been talking about with inpatient acute stays at Hampstead and now at New Hampshire Hospital on a temporary basis. And so that's a program that we've wanted to support for a number of years. And that also is subject to a procurement right now. I think I'll pause here and let you read through and see if you have any specific questions, because I think a lot of it has been addressed and this is the operational details.
Like the workload measurements. Thank you. It's nice to know how much work is getting done.
So, go ahead.
Representative Wallner had a question, I think, on that slide right there.
So, well, I don't know that it's on this slide, but this seems like a place where I might be able to ask this. There was the suit that was brought against the department a few years ago, the community mental health, and then we had the community mental health agreement. Mm-hmm. And on a fairly regular basis, I don't know what it is, a couple of times a year, maybe, or quarterly, it gets reviewed by an expert.
Yes.
How are we doing on it? I mean, I've kind of I kind of glimpsed at the most recent report, and it seemed like we're still out of compliance in certain areas, but I wondered if you could talk for a minute about those areas, and this might not be the right slide. I didn't know where to put this in, so.
So, Mr. Chair, I would request that we hold that until we get to the Bureau of Mental Health Services. The Bureau for Mental Health Services addresses the adult population, which is the subject of the Community Mental Health Agreement. The Community Mental Health Agreement does not address children's services.
Great, thank you, Kyle.
Yeah, let's do that. Representative Wallner's fine with that.
Yeah, let's put that in the parking lot.
Great. And again, we picked some select data to provide to you. And so this really shows the number of children that are being served by the community mental health centers. And I should say centers instead of services, I believe. But we've seen that growth, and I think that we have heard from others previously about why we're seeing these increases.
So I'm curious about this data in a different assessment. You know, how many of these clients are 18 and older? I'm just sort of curious about the demographics here.
So I think that's something, I just saw Erica shake her head. So I think that's something we'll have to take back and see if we can bring back to you and do it by age cohorts.
Actually, I can answer that if you would.
Oh,
And
great.
then,
Go ahead.
and then I'd be curious about the complementary slide that could go with it, which would be, who are we not servicing? Are there communities that we should be addressing where we're just not doing a great job of getting our care network into their community?
So again, Erica did say she could address the 18 plus, and I think she'd be happy to entertain the second question as well.
Absolutely. So this client count actually does not include 18 to 21-year-olds. Those will be represented in Julianne Carbon's graphs for the adult mental health side. We are in the process of adjusting our rules for the child eligibility to go up to 21, but this is not represented here yet. I would say in that vein, that is one area where we need to have some focused attention, is engaging in that young adult, transitional aged adult age group in more targeted engagement and more targeted services for that age group.
Okay, so earlier, one of the departments said they considered, essentially said, not literally, but essentially said that they considered adulthood to begin at 18. So it's sounding a little bit like we have multiple divisions aiming at servicing that 18 to 21 year age group. And I just wonder if that's by design, and if it's a smart design, or if we are maybe making a mistake having two different divisions trying to take care of the mental health of that age group.
So go ahead, Erica. What are your thoughts on that?
Certainly, when our bureau was established, we really wanted to align who we care for with other entities such as schools, who take care of and educate kids up to 21 if they have a severe emotional disturbance and have an IEP that requires them to be in school till 21, so that we don't cause any sort of cliff effect that other service sectors experience.
Okay, so the other part of that question, and maybe it's just something for the department to talk about, is just making sure that there's clarity around who owns what part of the mission for the 18 to 20-year-olds, because it sounds like there's more than one bureau or more than one division that does. So it just, in my past, it just seems like when more than one group is responsible for something, it causes problems.
I can jump in there a little bit, Katya, if you'd like. So I would just say that, yes, there are multiple divisions that serve people who are 18 to 21, depending on their needs and what services they qualify for. I think the last presentation you heard about was from Chris Santinello. And I think that there were different eligibilities for programs that provide payments potentially to people in that age group. I think that behavioral health wise, Erica has explained what's covered here. The other area that you will hear about 18 to 21-year-olds would be over in developmental disabilities, which I believe that presentation is next week. But I would say that as far as coordination, that I from what I've seen coming from a different department, the directors here coordinate very, very well between programs. There's always more work to be done, but it certainly isn't siloed to the point that they don't know what the others are doing.
I think we heard that the PATH Center, the youngest a person could be was 18 to be over in that building, for example. So, all right, we can continue.
Okay, so this slide talks about the eligibility category. And so there are different eligibility categories that we have. And this is, it shows all of the trending is up. And if there's specific questions about eligibility, now would be the time to ask them. And I think Erica would be prepared to answer those questions.
So CMHC, that's community mental health, not Catholic medical?
That's
Right.
correct. That's a community mental health centers. And so the 10 centers that are designated across the state.
Okay.
For example, in Concord, you have Riverbend. In Manchester, you have Manchester Mental Health. You have Seacoast Mental Health. You have Northern Human Services in the North Country, etc.
Okay. All right. Yeah, are there any questions here from anyone? No, I'm not seeing any.
So I think I mentioned before, CME is care management entity that oversees the Fast Forward program and the wraparound services. And you'll see the number of enrolled has continued to increase. And so this is an area of growth that we have moved to having to 2. So you'll see this one. And by the way, I'm so proud of myself, NFI, which you see here, which is a provider of housing services on campus, as we talked about earlier, is Northeastern Family Institute. And so they are very similar to KFC. They're never known as Kentucky Fried Chicken. They're always known by their acronym, which is, in this case, NFI.
Very good.
So the New Hampshire Hospital can cross that off their list of things to get back to you on.
So we have to get back to them and tell them to put the E in there if they're Northeast. That's all right.
All right. And so we just got this in place in October, which seems like yesterday, which is the second care management entity because of the anticipated growth. And you can see that they're ramping up their services to provide the services. They cover mostly the Monadnock region in the western part of the state, while NFI covers statewide all the other areas of the state. I do want to mention, because this impacts when you look at the staffing for the Bureau, is that we determine eligibility for this particular program. So the key accomplishments, Erica did an amazing job of hiring and staff and onboarding them during the pandemic. So as you can imagine, that was difficult, but has been very successful It did help that we were able to hire some individuals who already were working within the department and wanted to take on the new initiatives and the excitement that we have around these opportunities. So the 10-year mental health plan, when we talk about that, I think people default to thinking that it addresses adults, because our previous plan that was established in 2008 only addressed adults. And we were bound and determined that in this current mental health plan that it would cover all populations and put an emphasis on children.
Okay, so I have to ask, how would one assess an infant to determine if they have mental health issues?
That's a very good question. Erica, would you, Erica was very involved in the development of this mental health plan. And I will say that we partnered with other parts of the department. And so Henry Littman, our Medicaid director, was also involved in the development of this plan through an initiative that was funded by, I believe, the National Governors Association that recognized this was an area that needed attention. Go ahead, Erica.
Certainly, that's a question that we get asked a lot. And it's a question I had a few years ago before I went to that training in Minnesota. So there is a diagnostic manual for infants and very young children that is a companion to the diagnostic manual clinicians use for diagnosing older children and adults. So there is a companion piece there. And so most of it centers around the infant and any sort of growth, development, or milestone not being achieved. And there's a focus on sort of sleep, feeding, and crying issues that may a parent of an infant may experience. And then there's also an emphasis on the parent-child bond. So there are things when you're assessing, I think everybody's fairly familiar with a developmental assessment of an infant. If milestones aren't being reached, that's definitely an area of concern and would need some medical rule out, but also could be attributed to some behavioral health issues that can be addressed through treatment.
Let's go to the next step. Let's say that in fact you can assess the mental health of an infant. Since most of our mental health treatment these days seems to be with psychotropic interventions, what are we doing if we assess an infant with mental health issues? Are we drugging them? We're certainly not counseling them.
We are not. We're educating the parents, and we are treating the parent-child bond. Most of our infant work is about the return and response between a caregiver and an infant. So that is what is emphasized in treatment. So a lot of focus on the parent and the parent education as well.
So doesn't that get filtered through a bunch of different cultural lenses of what a parent-child relationship ought to be? I mean, there's not just one way to parent-child. There are multiple cultures. So
absolutely,
I'm still having problems figuring out what we could do effectively in this area.
Correct. So all of our services need to be looking through the lens of cultural competence. So if you are serving a family and a child that is experiencing issues that is from a different culture of yours, you really need to be educating yourself on what those cultural standards are during that. But it's really all about focusing on the issues that may bring a child to a assessment of this nature. Or what is found through a primary care well-child check and those developmental milestones not being achieved. So if everything else can be ruled out, then we need to look more closely at the behavioral health, the home environment, and the parent-child caregiver relationship.
Okay, Someday, not in this budget cycle, I'd like to talk about how you measure effectiveness of a program like that. I don't know how you get your arm around success metrics, but anyways, that's too much
And
conversation.
that's to be determined, actually. That's part of our development, that we have to determine what those metrics will look like.
Okay, great. Thank you.
So getting on to key challenges, I think you're going to start seeing some repeats here. So workforce, again, the system expansion is really hard to do when you're just holding on through a pandemic. The Medicaid primary funder for the services developed by Children's Behavioral Health. And so we use state general funds to fill in the gaps when we cannot bill Medicaid. And so we've seen children enter the system through the pandemic that have never, ever entered the system before. So some of those children are commercially insured, and some of them are in families that aren't insured. But really we've been working with the legislature actually on this commercial insurance side, because Medicaid will pay for services that we've built up over time that commercial insurance has yet to catch up to. So we need to make sure that we're addressing all children's needs rather than just those who are on Medicaid. And then again, looking at the staffing and transformation of the system and overseeing the network throughout the pandemic. We work very closely with the Department of Education in overseeing the system of care, because that is a statute that addresses both departments working together, knowing how critical it is with those school-based programs. And I hope Karen is here, but she may or may not be, but Jane should be. There's Karen.
Oh, I'm here. I'm multitasking. Sorry.
Yeah.
So the charts here, this is similar to the other pie chart with 2020 and 2021, and Representative Woolner was referencing this earlier, that if the funds had been contracted in a more timely way in 2020, the general funds would look very similar in that middle pie chart compared to the pie chart on the right. The new other funds coming in there are a grant that DOE has received that they are working with us on. So that's what those funds coming in as other funds are there. This
I also should.
I was just going to say the large increase in general funds, which I know Katya has spoken about, is really bringing that children's system of care together and bringing those contracts in place, all of which will help DCYF quite a bit in the future to reduce the number of children who enter that type of thing.
I don't want to sound mean, but I probably can't help it here. How do we know? I mean, we have a theory that early intervention, even at the infant level, is going to result in some successes, but we don't have any way to measure it, so we don't actually know whether or not this is a valid theory at this point. So how do we say money invested now is we're sure is going to positively influence the DCYF community in the future? I'm missing something there.
So I'm sure Katya will jump in there, but I would also just suggest that you also ask that question of Joe Ripsum, because this is a system that they stood up in New Jersey where he worked previously. So he has some lived experience with it as well.
Okay.
Sorry, go ahead, Katya.
Yeah, and I'll just quickly mention that evidence-based practices that have been proven to be effective are what we're employing. So when we implement something, we look at first to see if it's an evidence-based practice or a promising practice. that has been tested and studied and researched, and implementing that to really get at those outcomes that you're talking about. And we're going to be measuring this. It's not like we're just going to spend money and have no accountability with that. So we're going to be measuring it as we go along. I did want to point out something that you'll see. I believe it's a class note in HB1. This children's behavioral health has been one area in this division which has not had non-lapsing language between the 2 years that make up the biennium. So we did have funds. I know there's been concerns that have been raised about lapsed funds for children's behavioral health. Those funds would not have lapsed if we had had that language that allowed us to carry the funding from 20 to 21. And so again, that was something that we needed to put in, and it's in there. And we're also working with a legislature on some on a bill that would not allow the funds to lapse at the end of the biennium, but to carry forward the funds so that they remain committed to this effort for the system of care.
Lots of questions here. Representative Wallner.
I just wanted to know whether or not the children's behavioral health area received all the funding that they requested, and what were did you have anything on your priority list that you did not receive?
So unless somebody jumps up and down, we did receive all the funding that was requested to continue these services. And there were no prioritized needs because everything was already in the budget.
Yes.
Do you have a follow-up?
No, that's what I wanted to know. Thank you.
Representative Weiler.
Thank you, Mr. Chair. The way I see this going is we won't rest until we have 100% of the children having an annual psychiatric exam as well as an annual physical. I mean, it's just, there's lots of things that I've witnessed in myself and my children growing up and my grandchildren that they have, dream worlds they live in for a while and they grow up. And, some of these things were so deep that one grandson could only be referred to as Batman. He wouldn't answer to his own name for a matter of months. But I mean, this kind of thing, we suddenly call in mental health people. And I don't, he outgrew it in 6 or 8 months. So some of these things I think are overreacting, and this growing a bigger and bigger percentage of the children who are likely just going through normal phases of growth. It just doesn't make sense that this is growing this much. I don't think we have this big a problem in our society. Thank you.
So could I suggest a possible way to address Representative Weiler's comment? And it sort of would feed my issue too. And that is, you say we're using evidence-based models. It would be nice to get kind of a summary of what we're doing. What evidence are we looking at? What is that within this budget cycle? I don't know. Maybe it has to be. But at this point, we have a lot of programs that we know are addressing real medical needs that need to be funded. So, all right, let's go. Let's keep going.
So this gets to the 5% up and down. And so you can see where we would expand. We talked about the infant mental health. We've talked about the care management entity and their capacity. You saw the growth in that and the increased demand for those services. Erica told us, I forget how many applications they're getting a day for individuals seeking those particular services. And then we would look at enhancing community-based treatment options to therapeutic day treatment and intensive outpatient treatment. I will say, just to go back to the previous slide where we see the huge jump in general funds, we are working on a couple of initiatives that would allow us to match those funds with Medicaid. And so while some services aren't currently covered by Medicaid, we're hoping that we can use that as a tool and a resource to be able to garner that 50% on some of those funds. So the decrease, we would have wait lists for those high fidelity wraparound services. We would not be able to move forward with the mental health plan for infants, and would only be able to do it on a pilot basis or a very targeted basis. And we would not be able to support those children who aren't currently covered by Medicaid. And there's the 9 staff that we've talked about. And benchmarks. So again, fast forward program, we have been able to keep up. We're worried about keeping up, but we have been able to do that with additional staffing resources that were provided. The quality assurance reviews are really important. And then the assistance and consultation for the children's behavioral health programming. I can't tell you the demand on Erica's time and for her staff. They are constantly bombarded with requests to provide that technical assistance and to present information about children's behavioral health. And so that's across the board within internal and external.
Tim, are there any questions here? All right.
And then I'm going to turn it over to Karen.
If you want to stop screen sharing, I'll go ahead.
Sure. I'll try not to do a bunch of other things at the same time.
All right. Okay, so we're going to start on page 1118, which has only the title of this accounting unit. So I'm going to go ahead and go to page 1119, which is accounting unit 2052, Children's Behavioral Health.
And this has further accounts associated with it, right?
Yes, this is really like the other area is the administrative part of the Bureau.
Right.
So I can go ahead and go down to the next one, which is 2053, which is the system of care, the children's system of care.
So in 20, we were spending about 1.8 million, and we're proposing in 23 to get to 15.1.
Yeah.
Are those all general funds for the most part?
There is about 750,000 of federal funds and a little bit of other funds, which is that grant from the Department of Education.
Yeah.
And I will tell you, based on what I know of and have seen for contracting activity in this area this year, I do believe that we will spend most of those funds in 22 and 23.
Very good. Any questions here? You need another moment to look at it, Representative Weiler, Bean,
I
Rogers?
just think it's unsustainable growth. We don't have the revenue coming in to support this kind of growth in any of these programs.
So do you have a question, Representative Weiler?
Where does this department think the money's coming from? 45% in general funds and so many of these things. We don't have that kind of revenue. We don't have that kind of revenue sources. These are just not going to work.
So what, if you were to look out to the next biennium, is this kind of this geometric progression going to continue next biennium as well?
Katya, do you have any insight, or Erica?
I would not anticipate that it would grow at this. We had a system that wasn't a system. We're building a system to address the needs of children and to get to the point of how do we talk about cost avoidance. I think we look at Division 2 or Division 1, whichever one, and look at the costs in safety and look at the costs in our criminal justice system. And so if we get this system in place, we're going to have the services and the supports that are needed for families and children that will really have a significant impact on families in the future and where they end up in the trajectory of children. We always think in 2-year terms, but we really, when we're building a system like this, we're looking 10 years out.
Representative Wallner?
Yes, Erica and Katya, I'm wondering, what do people talk about at the federal level about a children's system of care? And do you see a future there that the federal government will get more involved in these kinds of programs? Because like Katya just said, it prevents large expenses in other areas, but it's going to take us a while to really build a system and really get to the point where we're saving those funds in other areas. So what do you think the future for the federal participation might be?
Eric, go ahead. I see you unmuted. So go ahead.
So I think we'll see more federal participation for this. We have availed ourselves of many different iterations of system of care grants. We have seen through our work with the federal Medicaid office and building our Medicaid benefit for the Fast Forward program, we're seeing their sort of hearts and minds open a bit wider around what needs to be invested in by Medicaid, by the federal participation for kids and families, and not just having a narrow view of what they would pay for. So we're seeing them broaden their perspective on what is necessary to support these children and families with severe emotional disturbances. So I think you'll see in the future more federal participation than we've seen. There was a huge push to develop system of care. And again, we've had about 4 different system of care grants for New Hampshire to build upon what we've developed over time. And I think you'll see more broader sort of assistance there.
Thank you.
You have a follow-up?
No, not right now. Thank you.
Okay, anytime. So which state or states are furthest ahead with implementing a system of care model? And do they have demonstrable results to show that some of the assumed benefits in the out years are actually real?
So I'm going to let Erica address this. I know that we do have states that we look to, and this will be another question that will be really important for DCYF Director Joe Lipsum to address it based on his experience in New Jersey. Go ahead, Erica.
So our key partners in the beginning of our system of care development has been Wisconsin. Wraparound Milwaukee was our training partner. They trained us in system of care and high fidelity wraparound. And they have seen demonstrable returns on investments in the areas of children in DCYF, either CPS or juvenile justice, and a reduction in acute hospitalizations for folks with psychiatric concerns. So there's a real return on investment there that is seen nationally and not just in Wisconsin. And we've also most recently, because of our relationship with Joe Ribsam now, we have partnered with New Jersey, who has really turned their system around in terms of right-sizing children's behavioral health and their child protection system. So he has lots to offer in terms of information, his experience in that system, and how he and I are working very closely to emulate that system. We took a number of legislators down to New Jersey so they could hear from folks there. And they had the same experiences wrap around Milwaukee, is a real decrease in those court-involved kids, either through CPS or JJ, and those receiving the right behavioral health service at the right time.
If I can just add in there too, from the previous presentation with New Hampshire Hospital Chair, you had brought up how do we serve more kids in the community? And this is the system that serves those kids in the community. This is what will bring down that wait list, which will, you know, like the CEO of the hospital mentioned, there are always children who will need the hospitalization services, but for those that we can reach earlier, this is the system that will do that.
So I'm trying to think, I'll get to you, Representative Wallner, in just a second. Just I got a follow up here. So in terms of demonstrating results, I kind of look at an evolution of knowledge to go from good theory, good anecdotal information, experience-based, to academic peer-reviewed studies showing cost-benefit analysis, to something that's even subjected to a performance audit, to where results are tested by consultants and demonstrated to be tangible. So where do you think, say, New Jersey or Wisconsin is in that sort of evolution of knowledge relative to the results we should expect?
So I would say Wisconsin is about 20 some odd years into their system evolution. New Jersey is probably midway in that evolution. They're at around 10, 12 years, I believe. And we are probably at year 5.
Okay, so my question was more specifically, how have they documented their results? Can Wisconsin give us something that we could read and touch and look at what their actual results are?
Yes, and actually system of care is well documented nationally as to what those return on investments and outcomes ought to be. And we are on par with those, and we can certainly share the national outcome literature with you.
Okay, so I think based on where we're at with the status of our revenues going into the next 2 years, we really need to see something that gives us confidence that this is money well invested. I'm not saying it isn't. It's just new, and it's just relatively a lot of money compared to what we have to look for. So if you could help us help you, that would be great. Representative Wallner.
Yes, hi. I guess my question is, in 2020, we were only spending, we were spending less than $2 million here. So really, we are really at the infancy of building this program. And we're just starting to really get the program up and ready so that we can start seeing some of those results. And it seems like the future is that we would see a lot fewer children at needing hospitalization, which is probably one of the highest cost programs that we have in our budget. Is psychiatric hospital is probably one of the highest cost things that we do. So it seems like this is money well invested in order to try to bring down some of those other high cost programs.
I think we should maybe defer an interactive conversation on this to our working session. Are there any other questions from the committee? All right, we can continue.
I would just ask when this just get discussed at a working session that we make sure to schedule Joe Ribson to also join that discussion.
We have a working session scheduled for Wednesday, and I suspect that Mr. Ripple can, it's in our house calendar, but we can certainly make sure Mr. Ribson knows.
I don't think I'll be able to have the directors available for the meeting on Wednesday. It conflicts with governor and council, for which they also need to attend. So
Okay.
I know that you have several working sessions scheduled over the next couple of weeks. So hopefully we can,
This being
or
week,
maybe we could talk about it more on Friday and Joe Ribson's presentation and have Erica and Katya join that conversation there.
So we, as you pointed out, we have multiple working sessions, and the one on Wednesday is our very first one. And so I think we're not going to be making anything that feels like a decision. What we're going to be doing is learning to agree with one another about what kind of ways of working we're going to be doing and what the major issues are we need to look at. I doubt if Wednesday's going to result in any sort of firm budget decision. So I wouldn't worry about missing it, is what I'm trying to say.
Great. I will be there. I just know that the directors will not be able to join us Wednesday.
All right.
Okay, so the last, go ahead, sorry.
We can go.
Okay. The last accounting unit is 2059, which is a grant that appears to be ending during fiscal year 22. So there's not much to talk about on that one.
Okay.
So that is the last accounting unit in that area. There is still one more bureau in the Division of Behavioral Health.
Representative Weiler raised his hand. Yes, sir.
Thank you, Mr. Chair. I had a question while we had Karen Rounds here that's not relevant to this present, but maybe she can give me a quick answer. I've got a meeting tomorrow with my county commissioners who are really upset over the state increasing the cap 18% and taking $15 million of state funds out of the money that used to go into that. And so it's got to be picked up by the counties. It's going to cause a tax increase in the counties. That's the biggest one we've had. And so we're wondering why that happened.
So I think that's not something I can prepare to speak about right now. It's a much longer conversation than just a few minutes. We anticipate discussing that during the Division of Long-Term Supports and Services budget, which I believe is next week. That's where that county cap contribution is in an accounting unit in that division. So it would be best to discuss it then when I also have the division director available.
All right, I thought I could give
the
you some
increases.
quick answer when I see him tomorrow. Thank you.
You're welcome.
Okay, I think we're ready to plunge on. Does anyone need a break after that? That felt rougher than most of them. You okay, Ms. Fox?
I'm fine. What I do want to ask is whether you want to delve into the next bureau with addressing adult mental health services at this point in time. We're prepared to do it, but just want to check in with you because it may also take as long as this one. It may not have as many difficult questions.
Yeah, let me do a poll of the committee. I'm prone to wanting to go forward so that you guys are relieved of having to come back on Wednesday. But Representative Wallner, your hand is up. Do you have a question, or do you want to comment on whether we should stop or continue?
Well, it's 4:15, and I mean, I think we've been at it for a long time. I already have another meeting that I'm supposed to be at 4, so
Okay.
I do want to be here for this presentation. So if we could wait for Wednesday, that would be great.
For you, ma'am, we'll wait till Wednesday. So
Well, for Katya, it's really for Katya more than it is for me if she can come back.
Mr. Ripple, can we work out a time to finish this bureau?
I think, sure, I think whatever works for the department. You have the work session scheduled for 9:30 as usual on Wednesday. If they're able to start at that time, you can start with that and then go into a House Bill 2 conversation, or we can start with House Bill 2 and then finish this. I think it's really whatever.
We had planned it for 1 p.m. because of governor and council. That is a conflict for the directors.
Okay.
Yeah, so I'm going to be
Natia
presenting.
needs to be at governor and council.
I have one contract on governor and council, but I believe that there's a presentation at the beginning of that, starting at 10. So I need to wait that out. And I anticipate questions on that item. So that's just a limitation. And I don't see anybody being able to cover council for me.
Okay, so 1 o'clock though does work?
Yes, we blocked it
Okay.
off.
Then I think you could start with House Bill 2 in the morning and then resume this at 1 p.m.
Okay, outstanding. So Representative Wallner, do you have another question?
No,
Your hands-
thank you. Thank you very much. I appreciate it.
Okay, so I heard your request to adjourn for the day, but I want to give Representative Nordgren a chance to speak.
Thank
Yes,
you,
ma'am.
sir. So we won't have House Bill 2 on by Wednesday, a physical document probably, or?
Well, I don't think you'll have it in hard copy. I do think you'll have it because we just saw a draft a couple hours ago from OLS, and we all took a look at it and let them know if we had any concerns. And I think if they haven't already, they're about to email it to Representative Weiler for him to release.
So, but when will we get a hard copy?
A hard copy probably won't get until later this week.
Okay. Did that answer your question?
Yes, unfortunately, yeah.
Okay. All right, so I don't want to adjourn without allowing the attendees to raise their hand. We've talked a lot here this afternoon, and there may be some supplemental comments from the public. So if you have something germane to any of the things we talked about, or you think will help us make some tough decisions, you're invited to raise your hand. I'm not seeing any. So, oh wait, there's Mr. Norton. Go ahead, Mr. Norton. You've introduced yourself already.
Let me just move him over.
Yeah, he doesn't need to introduce himself again.
Thank you, Mr. Chairman and members of the committee. And just in the interest of full transparency, I want to let you know that while NAMI New Hampshire are not treatment providers, we do participate in the Fast Forward program providing family peer support. But I just wanted to add a couple of comments. One, that in the conversation, one thing that I think is important that was left out is that suicide is the second leading cause of death for our youth, ages 10 through 34, and young adults. And we've seen pre-COVID it's well documented the rise in anxiety and depression among our youth and young adults, and it's gotten considerably worse during COVID. So I just think that that's an important consideration as we're looking at things moving forward. And then, you know, at some point, perhaps when there's more of a conversation about mobile crisis response, but to Representative Weiler's question about how to pay for this, there is the Federal Suicide Prevention Hotline Act, which was signed by President Trump in October to create a 3-digit 988 suicide prevention number, which by everyone's agreement is going to become a mental health crisis number. And that does allow for charging a telecom surcharge to pay for crisis response services. I know people may not like that idea, but that currently the 75 cents we charge for every telecom bill in New Hampshire right now is paying for raising about $14 million in funds that pays for 911 in our state. So just something to consider, and that will be implemented nationally in July of 2022. So we need to be thinking about how all of what's been spelled out with mobile crisis and system of care folds into a crisis response for our state.
So I'm taking your comment to be potentially part of the answer to the question that got left open about how we would find a central, God, what's the word? The words just escaped me. The person you call in who distributes the calls, the central call center. That this 988 answer may be a potential solution to the question of how we're going to come up with a call center.
Well, it certainly fits into, yes, that overall, the central hub that the state is stepping forward, and it will tie into 911 as well as 211 in terms of the doorway. And probably Katya or someone else could explain a little bit more that, as they mentioned before, that the RFP, the request for proposal announcement relative to who is going to get that contract is due to come out relatively soon, and there would be more details about that presumably when that contract is announced.
So let's roll that into the Wednesday conversation, Ms. Fox, if you care to address it then. That'll give you a few days to think about it.
Sure.
All right. Anything else? Well, I see Representative Nordgren. Go ahead.
Thank you very much. Maybe we can include this discussion on Wednesday. Many of you don't know, but there's this group called Headrest here in the Upper Valley, and that's a suicide prevention hotline. They cover New Hampshire, even part of Maine and Vermont, and so maybe Katya can address how that fits into the whole system. I didn't bring it up today because I wasn't sure this is the right time. So maybe you can flesh that out a little bit on Wednesday.
We will be prepared to do that, which was part of our slide deck, as you can see, but we'll make sure that we address it specifically.
Yeah, they got money in the last budget, I think as a footnote, 200,000 each year. But I'm unsure if they got the money or if I had Kevin searching to see if it was included this budget, but I don't think Kevin's seen it. So maybe we could update that.
Sure, I can just say, yes, they got the money, and yes, it's in the budget and the plan continued support.
Okay, thanks.
And I would just add, Representative Nordgren, and yes, they are the certified crisis call center for the state that the 988 number would be directed toward at this point in time. Yeah.
Okay. Any other questions from the committee? Okay, thank you, Mr. Norton. And then last call for the attendees to raise a hand if they have something they believe would be useful. I know it can take a second to find the button. Okay, we're going to be back Wednesday afternoon. So if we adjourn without you finding the button, you can try again on Wednesday. So I think we're at the point where we can adjourn. Is anyone opposed to adjourning at this moment? Okay, well, hey, thank you. It's been a very long day. Thank you, Mr. Ripple. Thank you, everyone from DHHS. I really appreciate it. And we'll see you Wednesday.
All right.